啱啲嘅。
咁我哋對面有對面同一日球場，覺得冇人好。打同
有 Q&A 會我喺個 test box 度見。
哦，咁呢個 webinar 同台灣
先有。
哦，呢個係 AEG，總之 AEG 呢個 webinar。Okay, so good morning. Very welcome to the AEG Train the Trainer course this time in Hong Kong. So we are very, very honored to have Professor Ryosawa and Professor Chowdhury. They are both experts in interventional EUS, and we have them flew over from their country to teach all of us their techniques and tricks in performing a good and safe interventional EUS. So we're very honored today. So this workshop is a 2-day workshop. So this morning we will have the lectures and theories first, and hopefully we will have we will be able to engage you for some interesting discussions. And in the afternoon, we have prepared cases for live demonstration. So all of you will go down to our endoscopy center. So I'm sure all of you have registered and you are allowed to go into the center. And Professor Ryosawa and Professor Chowdhury will perform the cases. Today we have, I think, 7 cases, 6 of which are interventional EUS. One is EUS FMB for an interesting pancreatic lesion. So cases will be under general anesthesia or MAC. So hopefully what I would like to do is hopefully it's like a small group discussion instead of like, the live demonstration where it's always very well planned. You always put the best cases and nothing happens and, you don't get to ask the experts questions. So hopefully it will be an interactive discussion, and actually we have quite a lot of time. So hopefully we will be able to do it in a zigzag manner. So maybe one room will start first and we observe one room, the other room the patient will be undergoing anesthesia, and then we can swap from room to room so we can have some detailed discussion on really specifics on how to perform and when or when not to perform some procedures. So tomorrow morning we have asked some of our attendees to submit some interesting videos, and so also hopefully we will be able to have some discussion and opinion from the experts on special cases. Tomorrow afternoon, we have a hands-on workshop. We'll start from 1, and we have to evacuate the center by 5, meaning that all the equipment have to leave by 5. So we have to end the workshop by 4:30 at the latest. So we move the workshop from 2 to 1 now. So hopefully we'll be able to practice more, and we'll have 6 stations: 1 on a gallbladder drainage with the zoo stent, 1 with the wand drainage with the Spexis stent, an HGS with the metal stent, an RFA, a EUS GJ with the hot axials, and also EUS FMB with the new microtech needle. So hopefully all of you will get some experience on the different stents available. So I would like to now invite Professor Teo to give us an introduction on what AEG Group is, because this is actually an AEG TT course. So hopefully you'll be able to join us and benefit from the educational courses, and also maybe contribute in the future to the development of EUS in the Asia Pacific region.
Thank you, Shannon. So again, a very warm welcome to all of you. Many familiar faces here. And also a big warm welcome to all our faculties who have came abroad. So I would like to take this opportunity to introduce the Asian Years Group. Can we change the presentation? Okay, so Asian Years Group. So currently, Professor Kita Sensei is the president, chairman, and I am also the vice chairman for the Asian Years Group. So it's a big group of enthusiasts for US, but not only US, but also pancreatobiliary endoscopy. So we started up in 2011. So throughout the last 13 years, we have actually progressed quite a fair bit. From just a small group of enthusiastic endoscopists interested in US, and now steadily growing throughout all the years, And 2 years ago in Hong Kong, we did the Asian Years Congress. And this year, coming in 2025, we'll be doing the next Congress in Taiwan. So our aspiration, of course, is to promote US in training and education, and also assist young endoscopists in terms of growing in this field. And of course, our interest is always in performing studies, research collaborations, high impact journals, and also practice changing studies. So this is our current council. So we have President is Kita Sensei, and then we have myself, and then Natalie is the treasurer, and then we have the steering committee, one from each major country. We have several subcommittees. One is the education subcommittee, who is responsible for making study materials, a lot of videos, which is available in our website. The guidelines subcommittee, which we have published the first guideline on interventional US, and currently working on a new guideline on the ward-up necrosis. Research subcommittee is headed by myself, and we are regularly reviewing studies and also trying to promote conduction of international multi-center trials. This is the education subcommittee members. Actually, not everyone needs to be an Asian AEG member. Actually, many of them are young members who are keen in contributing to the subcommittee. So there are many videos available, so you can check out the AEG website if you are interested. This is the guidelines subcommittee. Again, we have published a few guidelines on interventional US, USFNA, FNB, and also the ablation of pancreatic cyst. This is the research subcommittee. We have 2 ongoing studies. One is on, we've published a few studies, and 2 ongoing studies on portal pressure measurement, as well as one on early versus delayed necrosectomy. In terms of members, we currently have 90 members. The membership is by invitation only, because if you are a member, then you actually can write a proposal to our society and propose to conduct a workshop. So we are inviting key members of each country to participate as a member, and also to contribute in terms of education and also organizing workshops. Since 2012, throughout the last 12 years, we have organized many workshops, 239 in total, local and interventional workshops. In terms of workshops, we have several levels. We have basic, and then we have a TTT, which is train the trainer course, more advanced. And then we then have interventional workshops, so looking at mainly interventional procedures. And we have organized 4 Asian Years Congresses since 2015, Korea, India, Tokyo, and then Hong Kong, and then next year will be in Taipei. Train the trainer workshop. In 1 year, we have trained 17 doctors. Local and collaborative workshop, 11 courses. This is just in 1 year. And interventional workshops, there are 2, so altogether around 15 workshops. And in 2004, we have several train-the-trainer workshops, including ourselves, Kita Sato in Japan, India, Bangkok, and also local collaborative workshop. Already 9 courses, interventional workshop coming up in one course, and also webinar, which is just started in this workshop. So these are just many posters of previously arranged workshops. So I'll just fly through them. Okay, these are trainer workshops. Okay. And then last but not least, every year we have a trainers AEG retreat. So it's usually held in the APDW meeting, so where everybody gets together and then talk about what they've done over the past year and also to propose activities for next year. So usually there will be around 20 to 30 proposals for workshops all around Asia. So I hope you enjoy the remaining of the workshop, and please engage yourself in some hot discussion, because our idea is to have a small group and everybody will discuss their cases and make comments. So please feel free to make any comments if you feel like. So thank you.
So I'm Dr. YTD and co-chair this session with me is Anthony. So we would like to introduce the first speaker, Dr. Shannon Chen. Actually, she needs no introduction. She's the course director of this trainer workshop. And Dr. Shannon Chen is currently assistant professor in the Division of Upper Gastrointestinal and Metabolic Surgery of the Chinese University of Hong Kong. She has vast interest in all the endoscopic and surgical procedures, including conventional gastric esophageal cancer, and now she embarked on a special interest in peritoneal surface malignancies as well. She is well known to be a pioneer and also active interventional endoscopists and performing all these US guided biliary and drainage procedures. She has published over 70 peer-reviewed journals, and she is also in the research committee, subcommittee of the Asian US group. Today, Shannon would talk to us about the US guided gallbladder drainage, for who and how. Thank you, Sharon.
Thank you very much, Dr. Lee, for a kind introduction. So I'm afraid some of you may have heard this talk already before because I've given this talk for so many times. So I've modified with some new evidence, especially for EGBD in surgical, potentially surgical candidates, which is quite a hot topic right now. So if you look into the World Society of Emergency Surgery, the gold standard of treatment for acute cholecystitis, of course, if the patient is a surgical candidate, the patient should go for surgery. If the patient is not a suitable candidate, we should go for antibiotics first. And if it's successful, then you can consider delayed surgery, or if the patient is not a surgical candidate, then we keep observe. If the patient fails antibiotic treatment, the next thing we need to think of is a gallbladder drainage, and in the old days it's a percutaneous drainage, and nowadays we have the ET-GBD, which is the transpapillary drainage, or we have the EUS guided gallbladder drainage. So these is now incorporated into major guidelines, EUS-GBD. And we all know that emergency lab chole, I see a lot of surgeons in the floor, that it does come with some complications, and the most worrisome complication is a CBD injury. And the computer's battery is running low. Do we have a cord? Okay. So today we're going to focus more on this. So for patients who we intend for EUS guided gallbladder drainage. So in fact, for these patients, as mentioned, there are three options. So either a percutaneous drainage, or a transpapillary gallbladder drainage, or a EUS GBD. So of course, if we compare between these two endoscopic drainage, ET-GBD and EUS-GBD, we know that ET-GBD, I'm sure all of you do ERCP. It's a feasible technique. It's a very safe technique because it is trans-papillary and through the normal route. The only difficulty for this procedure is that for patients with acute cholecystitis, there is always a stone at the cystic duct. And to cannulate this cystic duct, which is very tortuous and blocked, may be very difficult. So there are now techniques to mitigate this, for example, using the spyglass. Professor Pranam Chai from Thailand has actually just published a RCT using ET-GBD as an interim for surgical candidates, and it was a positive trial. So there was less acute cholecystitis while the patient was waiting for a lab chole. So this is actually quite a feasible option if you do have the accessories and the technique to do it. So of course, as mentioned, the problem with this technique is that it is difficult, and the technical success rate is only around 75 to 90%. So for EUS-GBD, the beauty is that in patients with acute cholecystitis, the gallbladder is usually very distended. The problem at that time when this technique was introduced was that there was no appropriate stent. So we're trying to pull together two non-adherent organs, and if it's not done well, there may be bowel peritonitis, there may be pneumoperitoneum, and the patient is not a surgical candidate. So it may pose a lot of problems if this procedure is not done well. And however, now with all the new stents and new techniques, this technique is actually also incorporated to the ESGE guidelines, where if the patient is not a surgical candidate, EUS GBD is in fact a plausible alternative to PT-GBD. And in this, it also mentions that EUS GBD is actually superior to PT-GBD if the technical expertise is available. So this procedure actually started off at the very beginning by Professor Todd Barron in 2007. It was done with a plastic pigtail. Subsequently, it was done with a fully covered stent with anti-migratory flaps here. And it was still feasible at that time. And then came all these different lumen-imposing stents. And of course, nowadays it is done via the hot axios, which we can do with a direct puncture. So this is a distended gallbladder, failed PTC drainage. You can see that the gallbladder is still very distended because the contents was very thick and the PTC was not able to decompress it. So with this hot axios, you can see that the procedure time can be very short and procedure can be relatively simple. So this procedure can also be performed, this is not hot axios, with a new stent called the Zeus stent. This procedure is a courtesy from Professor Teo. So you can see that this Zeus stent is a new stent developed by MI Tech. It's a Korean stent. The design is very similar to hot axios. That is actually Professor Itoi was the one who designed this stent. The full name of this stent is a Zeus IT stent, IT standing for Itoi. So you can see that how it's deployed is when it burns through. To unlock it, you have to rotate this gray catheter to unlock it. And to deploy it is very similar to hot axios where you push it backwards. So it is a backward deploying stent. So after you deploy the distal flange, then it's very similar to deploying hot axios where you pull back the sheath, like the step 3 from hot axios. And then you deploy in channel for the step 4, also like in hot axios. And then you push the stent outward. So you can see the distal flange is right here. And now we're trying to push out the proximal part of the stent. So this stent will be used for wand drainage later during the live demo. It will also be available in the hands-on workshop tomorrow. So you can see and practice how to use this stent. So, of course, these procedures are all done in very distended gallbladders, and a direct puncture is easy. It avoids the exchange of catheters. But for small gallbladders, and if you are not very familiar with the procedure, the needle-first approach is actually preferred because first you may consider injecting saline to distend the gallbladder further to make the procedure easier. Second, if anything happens, such as in this case, let's see. So in this case, it was done by one of our first case of our trainee. So the scope was not held very stably, and so the guide wire was not seen. And so they struggled to find the guide wire, and at the end. So am I able to fast forward the video because I can't see the bar in the. 哦，即係拉佢我呢度 ，OK。So the problem is the guide wire was lost during the view. And so finally, when we found the guide wire, so we deployed step 1. And he was unable to push step 1 in. You see it was hitting against the back wall. So with some struggle, he decided to, he pushed it all, step 1 all in. But in fact, you see from this retrospective video is that the gallbladder was pushed away instead of the stent being inserted inside the gallbladder. So what happened is when we deployed the distal flange, it was actually inside the lumen instead of inside the gallbladder. So with this case, with the guide wire in situ, it can be easily salvaged with another hot axial, another LAMS, or whatever kind of, you can use a fully covered stent or another lumen opposing stent. So with the guide wire, in fact, it is easily salvaged. So for small gallbladders, and if you're not very familiar, having a guide wire is always a good and safe backup. And after doing these, inserting these stents, with this new lumen opposing stent, we can clear the stones and hopefully can remove the stent later. So in the past, our protocol, according to the DREC study, was that we will do a cholecystoscopy 4 weeks later. And with we would do a forward viewing OGD scope with a jet function. We would insert it to the gallbladder and remove the stones. The choices you use are the accessories you use for ERCP. You can use BML, laser, whatever, until you clear the stones, and then you can remove the lamps. And because our procedures are done under IV sedation, we may take a few sessions for the stones to be completely cleared. And we repeat them 2 to 4 weeks each time until it's all cleared and remove the axial stent. So for this is you can use laser. You can in fact also use EHL or basket to retrieve the stones. And you can also, at the very end of the procedure, do a cholecystogram where you inject contrast in the gallbladder. And for this case, there was an incidental finding of a common hepatic duct stone. So ERCP was done in the same session. So in fact, EUS GBD, when compared to percutaneous drainage, we all know this landmark trial by Teo. It showed that when you compare EUS GBD with a PT GBD, EUS GBD has much less 1-year adverse events rate, much less recurrent acute cholecystitis, less reintervention within 13 days, and less unplanned readmission. And all these readmission and reintervention from the percutaneous group is from catheter-related problems like tube blockage or skin site infection. And in fact, with EUS GBD, probably because the lumen is much bigger, the pain reduction is much quicker and better than a PT GBD. And in that study, a logistic regression analysis showed that the predictor, only single predictor for recurrent acute cholecystitis is in fact the use of a PT-GBD. So if we compare the endoscopic options, there are in fact a lot of studies comparing, in fact also meta-analysis, comparing EUS gallbladder drainage and transpapillary drainage. And it shows that in terms of the technical success rate, EUS GBD is better. In terms of clinical success rate, it tends towards better for the EUS group. And in terms of overall adverse events rate, it's similar, but specifically EUS GBD has less pancreatitis, as understandably it did not touch a PD at all. And in terms of recurrent acute cholecystitis, EUS GBD is also much better. And if you compare the three together, PTC, ET-GBD, and EUS-GBD, in fact, it shows that with EUS-GBD, the technical success rate is similar to the percutaneous drainage group. Clinical success, it's similar between the between the PT-GBD and also EOS-GBD. And in terms of the number of procedures required, PT-GBD is required to achieve clinical success. PT-GBD is much higher. And for the long-term adverse events rate, of course, percutaneous drainage is much higher. And in terms of this network meta-analysis comparing these three modalities, and if you look at the chart, PT-GBD is also has a very high technical success rate, but the problem is also with the adverse events rate that comes with an easy procedure, which is a PT-GBD. And in terms of recurrent cholecystitis, EOS-GBD is also ranked best amongst the three. And in terms of reintervention, also EOS-GBD and ET-GBD are better than the percutaneous drainage. So to summarize, in fact, these are the three options we have. EOS-GBD, if you are used to the procedure, there is a high technical success rate and a low recurrent acute cholecystitis rate. For ET-GBD, there are lower rates of reintervention, lower unplanned admission, but the procedure itself is technically more demanding. For PT-GBD, it's an easy procedure, routinely done with high technical success rate, but the reintervention rate is the highest. So apart from acute cholecystitis, we can also do this procedure in patients who are already on a long-term percutaneous tube. So some patients have a cystic duct stone that is blocking the cystic duct and therefore requires a long-term PTC, which is sometimes a hassle to the patient. And in these two quite old studies, it showed that it's feasible. But doing EOS-GBD in patients with PT-GBD is actually much more difficult than doing a acute cholecystitis. First, because the gallbladder wall must be thickened and contracted, because the acute inflammation has subsided and it heals with a fibrosis. And second, sometimes the cystic duct may or may not be patent. And sometimes for these patients, we inject through the PTC to try to distend the gallbladder. But then sometimes if the cystic duct is patent and the gallbladder wall is thickened, you may not be able to distend the gallbladder at all. And third is sometimes the wall is so thick, and because when the gallbladder contracted, it's further away from the duodenum as compared to when it's distended. So it may be more difficult to puncture a gallbladder which is further away. And of course, after the procedure, if you're not sure, always keep the PTC in situ for at least overnight, because if anything happens, if the PTC is there, then at least the gallbladder has a means of drainage and it can manage a lot of complications. And the last thing is, if it is really technically difficult, ET-GBD is always an alternative, or a long-term PTC. Actually, sometimes it's unavoidable. So this is a video of a PTC convert EGBD in a contracted gallbladder. So you can see, despite injection of the gallbladder was not very distended. For this patient, the cystic duct was obstructed, so it's already not the worst. So you can see that the distance is quite far away. So needle first approach was attempted. So you can see that it was so contracted that with the needle, it actually pushed away the gallbladder. So you can't see the gallbladder here. So this is a gallbladder. So this is the very large interflange distance. So with a second puncture, the needle went in. It was confirmed on contrast. And of course, a guide wire was then inserted. So afterwards, a hot axios was used. But now you see that despite the scope, the duodenum and the gallbladder actually has quite some distance between. So it's not directly next to it. So reminding you that the interflange distance of an axial stent is 1 centimeter. So the distal flange is nicely deployed, and you see that the proximal flange is being deployed. And you see the stent, in fact, proximal part of the stent. And the scary thing is, even you see it, it can still disappear. Because the gallbladder is actually pulling back the proximal flange. So the interflange distance was too long, so you see the proximal flange is right here. Because the gallbladder is contracted, so it's impossible to pull it towards the duodenum. And so now the gallbladder is actually pulling the proximal flange away from you because the interflange distance was too much. And so in these situations, first you have a guide wire, you have a PTC, so everything is very controlled. So to salvage this situation, then you can insert a fully covered stent. Yeah, so you can insert another fully covered stent, or you can insert another LAMS. So you see that the stent is now being inserted. So a 4 centimeter stent was chosen, and then the stent was deployed. And because the PTC is in situ, you can still do a cholecystogram to check that there is no leakage. And so I think this video shows that when we do this procedure, it can be difficult. Second, the choice of stent is important because there are actually LAMS that has a much longer interflange distance. So for the Spexis and the Zoo stent, there is an interflange distance of 2 centimeters and 3 centimeters. So in fact, if we did use those stents with a larger interflange distance, this probably would not have happened. So knowing your accessories and also choice of stents is also important. So then the next controversy now, so EOS GBD is now very widely performed, is that after doing this procedure, what's the next step? So should the LAMS be kept on for long term? Should it be removed like us? So you do cholecystogram, remove the stones and remove the stent. So if you look in this study just published last year, it compared the 3-year follow-up for patients who had this procedure done. And for this, they inserted the LAMS for long term. They found that the adverse events rates was up to 26% if you keep it long term. However, most of it is related if the LAMS is inserted in a gastric location. So if you're planning to put the LAMS for a long term, so for example, the patient is very weak, you do not want to insert scope again, then perhaps a duodenal puncture for the EOS GBD is a better option. And to answer this question, in fact, I performed this comparison between our patients who had the LAMS removed and patients from Dr. Manolo in Spain. So for him, all of his patients, he keep it for long term. For us, we have all along go for the aggressive approach where cholecystoscopy and LAMS removal was done. So for the past 10 years, we compared all our patients. And in the ITT analysis, it showed that there was more recurrent biliary events in the group with cholecystoscopy done. So in terms of recurrent cholecystitis or recurrent cholangitis, it was more in the cholecystoscopy group. And also there was more late complications and more emergency room visits. And if you look also at the Kaplan-Meier curve on the biliary event-free probability, the long-term LAMS seems to have a better comparison. But of course, within this group of patients, there were some patients who crossed over to the other group because some of our patients who were too old and frail or those who refused a cholecystoscopy, so they became a long-term LAMS. So we also did a per protocol analysis. So in fact, with the per protocol analysis, the results were the same. So for the cholecystoscopy group, there was more biliary-related events and also more late complications. And of course, for long-term LAMS, we worry about stent erosion and stent complication. But if you look at this data, it seems that there was no difference in the long-term LAMS group as compared to the cholecystoscopy group. Of course, the follow-up time is only a bit more than 2 years. So whether it will cause more problems with a longer follow-up, we do not know. But these patients are frail patients, and you do not expect them to survive for very long. So these are just some food for thought. So this comparison, actually, the conclusion was that with a cholecystoscopy and LAMS removal, there was more recurrent biliary events in both the ITT and per protocol analysis. So perhaps for patients who are very frail, we may consider to keep the LAMS for long term. And how many patients, how many procedures do you think is enough number of procedures to do it independently? So in this study comparing the outcomes before 25 procedures and after 25 procedures, there was a significant improvement in procedure time. There was much less unplanned procedure events rate and 30-day adverse events rates if you perform more than 25 procedures. So maybe you would need at least 25 procedures for a EUS GBD to be independent, or call yourself an expert endoscopist. And of course, the next question is now we're moving on to whether this procedure can be done in surgical patients. The argument now is, if the patient is planning for surgery in the future, should we puncture the antrum rather than the duodenum? Because as surgeons, we know that repairing the antrum is much easier than repairing the duodenum. So there are actually studies already published. So in this first trial retrospective comparison between EUS GBD and PT GBD who had surgery afterwards, it showed that with the EUS GBD, the time from drainage to OT is much longer, but the OT time, procedure time itself, is much shorter. And so this first study actually concluded that at least lab chole after EUS GBD is safe and feasible, and there's a very low conversion rate. So this is one of the videos where robotic cholecystectomy was done after an EUS GBD, and this little adhesion here is probably where the LAMS was before. So the rest of the procedure then is like a normal lab chole. So the adhesion may not be as bad as we expect. Also, our friend Kunda has published this interval cholecystectomy after EUS GBD in DDW, and for him, he was able to do cholecystectomy in all of these patients. He did a transduodenal approach. The LAMS was removed before the surgery to allow the fistula to heal before the surgery, and the only 2 of the patients required conversion, and the mean operative time is 44 minutes, believe it or not. So, and also this year, Amy Tyberg from the States also published this study comparing cholecystectomy after EUS GBD and PT GBD. And you can see that for the EUS GBD group, the procedure time is much faster. The technical success rate is similar. And the conversion rate is also quite similar. So maybe it is not as horrible as we think. And whilst everything is pointing towards supporting this approach, G and also Cheyenne from the States published this letters to editor in Gut, saying that it should never be done in patients with who are potential surgical candidates. So in fact, it says here with a very strong wording saying that that the EUS GBD should only be reserved for a selective cohort of never surgery patients. So it then gave, in the literature now, everybody is a little bit, okay, so should we do it or should we not do it? But if you look into the small details, it was only a cohort of 25 patients, and 3 of them had a conversion. And I think 1 of them had a bowel duct injury, but it was not a direct comparison between PT-GBD, right? So we all know that we should, single arm cohort does not have any meaning and there's no comparison. And these difficult gallbladders, in fact, should be compared against percutaneous patients who had PT-GBD done because they are the same group of patients. So anyway, this is still out for debate, and maybe we would need further studies to prove this. And how about using EUS GBD as a definitive treatment? So even for surgical patients, if we clear all the stones, can we consider not to take out the gallbladder in the long run? Because in the past, if you are senior enough, you know that they do PTGBD, they dilate the tract, they do a percutaneous cholecystoscopy, they clear all the stones and they remove the PTC, but it always ends up in gallstone recurrence. So this is a very, very old, that lots of studies have been done before. So can EUSGBD change this, or do we have any new methods in preventing the gallstones from coming back? So to answer this question, in fact, in our center, we did 30 patients who are surgical candidates for EUSGBD. And during the same year, it took 1 year to recruit all these patients. During the same year, we had 79 patients who with acute cholecystitis who underwent lab chole, and we did a retrospective comparison between the two. So of course, there was the comorbidities are very similar because they are all fit patients. For EUSGBD, we routinely screen the CBD for bile duct stones during the index procedure for gallbladder drainage. So you can see that the concomitant CBD stone rate is actually much higher. So in fact, when we do emergency lab chole, I'm sure there is, even the liver function is normal, there is a 20% chance that there is a CBD stone. So this is a fact that we know. So we compare these two, the short-term outcomes. As expected, EUSGBD is much better because patient can eat the next day. There is no chance of bowel injury. The time to resumption is diet is much quicker. There's no ileus, there's no wound infection. So short-term outcomes must be better. But these patients are surgical candidates, so we're looking for long-term outcomes. So whether these gallstones will come back that cause clinical problems. So for our 1 year comparison, you can see that for EUSGBD, so for the EUSGBD group, we all do cholecystoscopy, we clear all the stones and we remove the lamps. So at 1 year, you see that 4 out of 30 of these patients had a recurrent CBD stone. One had biliary pancreatitis, one had cholangitis, and one had recurrent acute cholecystitis. And some of these CBD stones or pancreatitis may have been induced by the cholecystoscopy, because during cholecystoscopy, we need to fragment the stones into smaller stones. And during flushing, the small stones may have been flushed down to the CBD. We're not certain. So these are the early outcomes. So for lab chole, you see, in fact, out of the 80 patients that we have, 4 of them also have some biliary events. This probably is due to some missed CBD stone during the index surgery. So there was no difference in unplanned reinterventions, unplanned readmissions, and so we further went on to look at the 2-year outcome. At 2 years, more gallstones came back for the EUSGBD group and caused more biliary-related problems. And for the lab chole group, as our surgical wisdom has taught us, after the lab chole, after the first year, second year, the patient did not have any other biliary-related events. So it stayed at 4 out of 80. So statistically, it started to see significant difference between EUSGBD. And because of these recurrent biliary events, patient required more unplanned reinterventions and unplanned readmission. And at 3 years now, so this year is 3 year, you see that 2 more of these patients, so 10 out of 30 of these patients actually had recurrent stones, and then the lab chole group, then it remained static as expected. So at this juncture, this procedure as a definitive treatment for surgical patients definitely is not the gold standard. But if some of the patients strongly refuse a lab chole, this is an option, but you need to counsel them that we know that the gallstones will come back, and we know that they will cause biliary-related problems. And of course, we are trying to look into our database now to see if we can select better patients. So which patients may have, because as you can see, 20 out of 30 of them did not have recurrence. So which the patients are these? Are the stones smaller or cholesterol stones, or the type of stones may be different? So we're trying to analyze to see if we can find any better selection criteria. So to end my lecture, in non-surgical candidates, endoscopic drainage are superior to percutaneous drainage. In surgical candidates, lab chole is still the gold standard. Lab chole after EUS GBD seems to be safe and feasible. And EUS GBD plus cholecystoscopy for surgical patients are associated with better short-term outcomes, but in the long run, more recurrent gallstones. And perhaps further studies are required to answer questions on whether EUS GBD is suitable for surgical candidates. Thank you.
Thank you, Shannon, for a very interesting talk. We are slightly over time, so we can take maybe one or two questions. On the webinar, actually, I already have a question. What is your consideration when choosing a lamb's diameter size for EGBD? So what size of lamps would you use for EGBD?
For us, the routine size is 15 mm because it then leaves you an option for cholecystoscopy. If you use a 10 mm, an OGD scope will not fit. So, and in fact, the technical difficulty is similar between a 10 mm and 15 mm. So, if given a choice, I'll choose the 15 mm.
Do you place a plastic stent after EGBD?
I think it's a very personal preference, but for me, it will choose depending on whether there's a large stone that may impact and block the lamps. So if there's a large stone, then always insert a lamps. And if that patient I'm planning for a long-term lamps is that I'm not planning to go in further and the lamps is to be there for long-term, I would put a plastic stent just in case the lamps was impinging on the opposite duodenal wall, or long-term it may improve the stent patency. But it's a very personal thing.
Is there a minimal distance that you measure on the US that you allow you safely to place the lamp into the gallbladder, the minimal distance? And also, is there any difference between different lamps instrument?
So before all these new lamps is out, 1 centimeter is always a golden number. Is that between the duodenum and the gallbladder, because the only available lamps at that time, the interflange distance is 1 centimeter. So it has always been a golden number. Is that the maximum distance between your organ and the gallbladder should be 1 centimeter. And if anything more than that, apart from the lamp's structure, the thing is you need to make sure that there's no bow or anything that is in between, because normally the duodenal wall is very thin. So for acute cholecystitis, there may be some momentum wrapping around, the gallbladder wall is thickened, so there may be a larger interflange distance, but you just need to be very careful that there is no bow or large bow that is like in between that's making the interflange distance so wide. And if you are 100% certain, like in the long-term PTC converting to a internal drainage, you can consider using the longer interflange distance, but I think you probably have to be quite confident and expert in order to do that. I think for a very safe procedure, 1 centimeter should be the maximum distance.
What I'm asking actually is that the lumen inside the gallbladder, not the wall between that, the minimal distance between the lumen, in terms of
the size of the
gallbladder.
Oh.
Yes.
So it depends on the indication, right? So for acute cholecystitis, the gallbladder is usually distended. For EUS GBD for biliary obstruction, the gallbladder is usually also distended. So it is very, very uncommon that the gallbladder is collapsed, because the indication itself then is not sound, right? So unless it is just now a PTC conversion, then the gallbladder may be collapsed. For sometimes even for acute cholecystitis, the gallbladder may not be as distended as you like, but with a needle-first approach, and if you can manipulate the guide wire towards the fundus, with the guide wire, in fact, I don't think there is a very minimum size of the gallbladder that you can't perform the procedure, but you just need to make sure that the guide wire direction has enough runway for your lamps to be fully inserted for deployment. Sometimes, because just now the video I did not show very clearly, is that if your guide wire is sometimes pointing towards the CBD, then the guide wire would point towards the CBD and then have an acute turn pointing to the fundus. Then the runway for the lamps would be very short. then the lambs may not be able to make the U-turn as the guide wire. So if you are doing a gallbladder that is not very distended, try to aim the guide wire towards lateral, towards fundus, so then you have a longer runway, and so your lambs can be fully inserted.
So to supplement Shannon, so the axials is a backward deployment stent. So you need to insert it to a sufficient distance for it to deploy backwards. So in general, the size of the backward deployment is about twice the flange size. So you use a small size axials, so the backward deployment is less. So for example, if you use a 1 centimeter stent, you need to insert at least 2 centimeters into the gallbladder. And if you use a 15, then you might need to insert more, up to like 3 centimeters. I'll see. Yeah.
And in fact, on the hot axios, in the hands-on workshop tomorrow, we may be able to show you that, in fact, we always talk about the black mark on the hot axios. It's actually visible in EOS. So as long as that black mark is seen within your target organ, then you're very safe to deploy the distal flange. But we can show you in the hands-on workshop tomorrow.
Okay. One last question on food residue. So any difference in terms of how you puncture the gallbladder through the stomach or the duodenum, in terms of the risk of food getting in the gallbladder, and if it gets in the gallbladder, how to deal with it?
Okay, so if you look into the literature, to be more objective, there is no difference between inserting through the stomach or duodenum. If we talk about personal experience, we never do it through the stomach unless forced to, because as the question is quite correctly asked, we expect food residue to enter the gallbladder, which will cause recurrent acute cholecystitis. And remember, Professor Teo had a case before when we were in the very early days, where we just puncture wherever you think is convenient, and we inserted it through the antrum. Patient had the sepsis was not able to subside. She had persistent fever and persistent sepsis. The CT repeated. We thought there was a problem with the procedure, but in fact it was food residue that was in the gallbladder. And so we tried to insert plastic pigtails into the lambs, hoping that the food would not go in. I forgot how many stents you inserted. 9. So he inserted 9 double pigtail stents into the gallbladder, and we thought that the lambs completely covered and the food cannot go in, but still the food just went in and there was still persistent cholecystitis. So at the end, we had to fast the patient for 2 weeks to allow the fistula tract to heal. And then we removed the lambs, and then we sutured the opening of the stomach to prevent food from going in. So from that time onwards, we never did a case of transgastric puncture unless forced to, unless there is no options.
I think there's a very recent study actually showed the difference between transdural and transgastric puncture. So more adverse events with transgastric puncture. Okay, so thank you, Shannon. So next I would like to introduce Professor Ryozawa. Professor Ryozawa has been my good friend for many years. He's currently the chairman of the Department of Gastroenterology in Saitayama Medical University Center. He received his training in the very famous Hamburg University Hospital under Professor Nips Ohendra. His interest is, of course, in US, ERCP, and he is currently serving as a board member in many important Japanese associations. So Professor Ryozawa would give us 2 lectures, both on US bacterial drainage, but for different indications. One on malignant biliary obstruction, and then the other one for benign indications. So Professor Ryozawa, when you're ready, start.
Please. Okay, good morning, ladies and gentlemen. Thank you very much, Anthony and Professor Lee, for your kind introduction. It's my great honor to be invited here as a speaker. I want to appreciate Shannon and Raymond also for their kind invitation. In this lecture, I talk on EUS-guided BD for malignant biliary obstruction, risk management for safe EUS BD. Push here. Okay. I disclose my COI. As you know, endoscopic transpapillary biliary stenting was first reported by Professor Sohendra, my mentor. And now, endoscopic transpapillary biliary stenting is the most common procedure for biliary drainage in patients with obstructive jaundice. As you know, selective cannulation of major papilla fails in 3 to 12% of cases, and surgery or percutaneous biliary drainage is required. However, PTBD demands dilated intrahepatic biliary ducts, and potentially patient's QOL is lower. On the background, EUSBD was first reported by Giovannini in 2001, and recently, in the systemic review and meta-analysis compared with EUSBD and PTBD, there was no differences in technical success between two procedures, but EUSBD was associated with better clinical success, fewer post-procedural adverse events, and lower rate of re-intervention, and concluded that EUSBD may be preferred over PTBD if adequate advanced endoscopy expertise and logistics are available. More recently, ESGE guideline recommend EUSBD over PTBD after failed ERCP in malignant distal biliary obstruction. Japanese guidelines also recommend EUSBD in patients with failed or difficult ERC. There are several access techniques of EUSBD. First is EUS-guided choledochoduodenostomy, CDS. A stent is deployed at the fistula, which is created between the duodenal valve and extrahepatic bile duct. I show a video. CBD is punctured from duodenum in a long position, D1. Then, a plastic stent is placed. For this patient, of course, we may place covered metal stent like this patient. And now hot axios is also available, but not available in Japan. In US-guided hepaticogastrostomy, a stent is deployed at the fistula, which is created between the stomach and intrahepatic bile duct of the left lobe. Plastic stent, for this case, IT stent made by Professor Takao Itoi was placed in this case. In US-guided antegrade stenting, the intrahepatic bile duct is punctured transgastrically, and using this route, a stent is placed in an antegrade method. The hepatic bile duct is punctured transgastrically, and using this route, metal stent is placed in an antegrade method. Oh. No. Next. Okay. Rendezvous method, whereby the bile duct is punctured transgastrointestinally. A guide wire is advanced in an antegrade manner and pulled out from the papilla, and using this guide wire, the transpapillary approach is carried out to reach the bile duct. The bile duct is punctured transgastrointestinally. A guide wire is advanced in an antegrade manner and pulled out from the papilla, and using this guide wire, the transpapillary approach is carried out to reach the bile duct. There are three types of approach route for EOS rendezvous. We should choose the routes depending on the cases. If you puncture from the stomach, scope is stable. However, the distance to the papilla is long. If you puncture from D1, duodenal valve, scope is also stable. However, the needle direction will be hepatic hilar, so difficult to navigate the guide wire to the papilla. If you puncture from D2, second portion of the duodenum, scope is not stable. However, you can easily navigate the guide wire to the papilla. The patient's condition should be considered when selecting an EUSBD procedure. The location of biliary obstruction, presence of duodenal stricture, reconstruction method in case with a surgically altered anatomy should be evaluated. Park reported an algorithm for selection of the EUSBD procedure. According to this algorithm, EUS rendezvous is the first choice for cases with failed ERCP, but with an accessible ampulla. Whereas EUS HGS or CDS is the first choice for cases with duodenal obstruction, depending on the location of the biliary obstruction. The indication of EUSBD as the first choice for surgically altered anatomy is still controversial, especially in Japan, because many high-volume centers prefer to select ERCP using balloon-assisted enteroscopy. This algorithm of EUSBD is proposed by our Japanese group. EUS CDS, HGS, AGS, or EUS rendezvous can be used for patients with a regular anatomy without duodenal obstruction. EUS CDS, HGS, or AGS can be performed in those with duodenal obstruction. And EUS HGS or AGS can be used for patients with surgically altered anatomy. Minaga compared EUS CDS and HGS and concluded that similar outcomes for MBO between these two approaches. Giri analyzed adverse events associated with various types of EUSBD. Clinical results are similar in all EUSBD techniques, and despite a high clinical success rate, EUSBD may be associated with adverse events in 14% of the cases. Vinay also reported that the high technical success rate of EUSBD is associated with a high complication rate, including stent migration and death. In the technical review of 810 cases of EUS HGS, high technical success rate and clinical success rate has been reported, However, adverse events rate is also high, including rare serious adverse events such as perforation, mediastinitis, and intraperitoneal migration of the stent may happen. USBD procedure involves many technical steps, including puncture of bile duct, guide wire insertion, tract dilation, and stenting. If the procedure fails in any step, it may lead to serious complications. For puncture of bile duct, usually 19-gauge needle is used with 2.5-inch guide wire. However, when the bile duct is not dilated enough, 22-gauge needle will be used with 1/8-inch guide wire. Ogura reported that to prevent double mucosal puncture, careful monitoring for the double mucosal sign should be performed, and to prevent double mucosal puncture, the water filling technique may be useful. Next step is guide wire insertion. If the guide wire becomes kinked by the needle, guide wire manipulation may be difficult and can cause complications such as guide wire sharing or injury during EUS HGS. Nakamura reported river impaction technique. When the guide wire is advanced into the periphery of the bile duct, guide wire kinking and sharing of the guide wire against the needle tip can occur. If the needle itself is pulled into the hepatic parenchyma, difficulties with guide wire sharing or injury cannot occur during guide wire manipulation. Tract dilation prior to stent placement in EUS HGS is also an important step for successful procedure. If tract dilation takes too long or overdilation occurs, the risk of biliary peritonitis due to the bile duct leakage increases. Various useful tract dilation devices are now available, including an ultra-tapered mechanical dilator, tapered tip balloon dilator, and cautery dilator, and can be selected depending on the cases. We prefer to use ES dilator, which has minimal gap with guide wire. A coaxial cautery dilator is also available. Although dilation of fistulas using an electric cautery device is technically easy, it has potential risks of bleeding, perforation, penetration, and incorrect puncture. Therefore, the electric cautery devices should be selected when non-cautery devices is not effective. I show a novel rotary drill dilator, Turnus ES. The shape of the tip of the Turnus is drill-like, and it is hydrophilic at 30 cm from its tip. Two sizes available, 1/8-inch guide wire compatible and 2.5-inch guide wire compatible. Next, I show a newly long type balloon catheter. Using conventional 2 cm or 3 cm type balloon catheter, we need 3-step dilation. First, bile duct. Second, liver parenchyma. Third, GI tract dilation. However, using a new long 6 cm type, we can perform one-step dilation of all the 3 parts. Ishiwatari investigated whether bile aspiration during EUS HGS decreased the rate of post-procedural adverse events and concluded that bile aspiration of more than 10 ml during EUS HGS contributes to reducing the post-procedural adverse events. So bile aspiration should be routinely considered to decrease the risk of fever and abdominal pain in patients undergoing EUS HGS. A plastic stent and a covered CEMS can be used for USBD. Metal stent has a potential risk to cause complications by overexpansion of the intrahepatic bile duct, and metal stent cannot be exchanged easily. So some doctors, including me, prefer to use IT stent designed by Professor Itoi, which is a dedicated plastic stent with tapered tip and pigtail for US HGS. Tapered tip makes stent insertion easy. On the other hand, a covered metal stent is recommended because there are risks of bile leakage along the fistula and stent migration when using plastic stent. Now, partially uncovered metal stent for US HGS to prevent the side branch blockage are available. And more recently, a dedicated metal stents with anti-migration function for US HGS are developed. More recently, the comparison between US CDS using LAMPS and ERCP using covered metal stent is reported by Anthony. They showed that US CDS was associated with higher technical success and shorter procedural time than ERCP, and concluded that primary US CDS may be preferred when difficult ERCPs are anticipated. Chen also reported that, although not superior in stent function, US CDS is an efficient and safe alternative to ERCP metal stenting. Their findings provide evidence for greater adoption of EUS CDS in clinical practice as a complementary and exchangeable first-line modality to ERCP. I want to conclude that USBD can be recommended in patients with failed or difficult ERCP. Despite its clinical utility, USBD can be complicated by severe adverse events. USBD procedure involves many technical steps. It is essential for safe performance of USBD to understand the causes of technical failure and adverse events at each step. Thank you for your kind attention. Okay, so I continue my second lecture. ERCP has been utilized for the diagnosis and treatment of biliary tract diseases, both benign and malignant. However, ERCP is technically difficult in some conditions, such as surgically altered anatomy and gastric outlet obstruction. PTBD has been used as a salvage technique for failed ERCP. However, it is associated with high morbidity. There are several reports on comparison of USBD and PTBD. Lee reported that EUSBD and PTBD has similar levels of efficacy. EUSBD produces fewer procedure-related adverse events and re-interventions. Atphone reported EUSBD can be an effective and safe alternative to PTBD with similar success, complication rate, cost, and quality of life. And as I mentioned in the former lecture, in the systematic review and meta-analysis compared with EUSBD and PTBD, there was no differences in technical success between two procedures, but EUSBD was associated with better clinical success, fewer post-procedural adverse events, and a lower rate of intervention, and concluded that EUSBD may be preferred over PTBD if adequate advanced endoscopy expertise and logistics are available. EUSBD has been increasingly performed mostly in patients with unresectable malignant biliary obstruction. However, the indication of EUSBD are not limited to malignant biliary obstruction, and the use of EUSBD for benign biliary diseases is increasingly reported. This slide shows the indication of EUSBD in benign biliary diseases. As the reasons for interventions, bile duct stones and benign biliary strictures are two major indications of EUSBD. EUSGBD for cholecystitis has been already described by Shannon, so in this lecture, I will not mention the EUSGBD. The reasons for EUSBD are failed cannulation, failed access to the ampulla or the anastomosis, failed guide wire passage through the stricture, and clinical failure after ERCP. In benign diseases, EUS rendezvous, EUS antegrade intervention, and EUS HGS HJS are three major methods for EUSBD. EUS rendezvous is performed for failed biliary cannulation in patients with a regular anatomy. EUS antegrade intervention is performed for stone removal in patients with surgically altered anatomy. And EUS HGS HJS is performed for anastomotic strictures in patients with a surgically altered anatomy. In EUS rendezvous, after the puncture of the biliary tract, a guide wire is passed through the ampulla into the duodenum or through the anastomosis into the jejunum. Then, by using this rendezvous guide wire, biliary cannulation is achieved in an ERCP fashion. Subsequently, intended procedures such as stone extraction and biliary drainage are performed. The bile duct is punctured. Transgastrointestinally, a guide wire is advanced in an antegrade manner and pulled out from the papilla and use this guide wire. The transpapillary approach is carried out to reach the bile duct and then subsequent procedures. In a systematic review of 15 articles, included 382 EUS rendezvous cases, Itoi's group reported that the overall success rate was 81%, 85% in the extrahepatic and 66% in the intrahepatic approach, with complication rate of 10%. As I mentioned, there are 3 routes in EUS rendezvous: transgastric, transduodenal long position D1, and transduodenal short position D2. Transduodenal route in a short position is recommended whenever possible because of its easier guide wire manipulation. There are some techniques that can enhance the technical success of EUS rendezvous. EUS guided hybrid rendezvous is utilized if the guide wire placement into the duodenum is difficult or impossible because of downstream resistance during the IHBD approach from the stomach. Then a 6 French bougie dilator with well-tapered tip for smooth dilation was inserted into the biliary system during the EUS hybrid rendezvous procedures. Hitch and ride technique uses a cannula which has a slit on the tip to catch the rendezvous guide wire. Next, I talk on endoscopic management in a surgically altered anatomy. As you know, ERCP is an essential tool for therapy of various pancreaticobiliary diseases, with success rate in excess of 95% in patients with normal anatomy. In contrast, ERCP with conventional equipment in patients with surgically altered anatomy has had limited success, peaking at only 51%. There are many kinds of surgically altered anatomy. B2 with short afferent limb is relatively easier to insert, but long afferent limb will be challenging. This slide shows several variations of Roux-en-Y anastomosis, with total gastrectomy, partial gastrectomy, or hepaticojejunostomy. Pancreaticoduodenectomy is also difficult to insert. In patients with surgically altered anatomy, the long length of the afferent limb and the acute angle of anastomosis preclude endoscopic access for ERCP. However, the development of balloon-assisted endoscope have changed the situation. Originally, conventional 200 cm long-type balloon-assisted endoscopy has long working length and small channel of 2.2 to 2.8 mm. So we cannot use many conventional devices for ERCP. Now, short-type balloon-assisted endoscopes are commercially available. We mainly use Olympus short single balloon endoscope. Short single balloon endoscope has a 152 cm short working length and wide channel of 3.2 mm, larger than 9 French. So we can use many conventional devices for ERCP. With short-type double balloon endoscope in patients with surgically altered anatomy, in multi-center prospective study in Japan, 92.3% of overall success rate was reported. This slide shows the result of multi-center cohort in Japan, 1,318 single balloon endoscopy assisted ERCP procedures from 8 high volume centers in Japan, including our hospital. The endoscopy success were 88%, biliary cannulation success were 87%, and procedural success rate were 75%, with small rates of adverse events in 7.7%. This result shows that single balloon endoscopy assisted ERCP seems very effective and safe. This table shows procedures we have performed, mainly stone extraction and biliary stent placement. This video shows metal stent placement for Roux-en-Y case with distal bile duct stricture. Sphincterotomy was performed using a new sphincterotome dedicated to surgically altered anatomy. We made an incision to the 5 o'clock direction, then placed fully covered metal stent successfully. Of course, we may perform EUS antegrade intervention for stone extraction in a surgically altered anatomy. Puncture B2 transgastrically, pass the guide wire to the bile duct, then to the duodenum through the papilla, perform papillary balloon dilation, now perform balloon dilation in antegrade manner, followed by additional large balloon dilation. Then push out the stone into the duodenum using extraction balloon. Iwashita reported 72% of successful stone extraction with EUS antegrade intervention. Takasaki compared EUS guided intervention with balloon-assisted enteroscopic ERCP for CBD stones in surgically altered anatomy and reported the shorter procedure time in EUS guided intervention, but the technical success rate are comparable. Iwashita also compared EUS guided intervention with balloon-assisted enteroscopic ERCP and reported shorter procedure time in EUS guided intervention, higher endoscopic approach, but lower success rate of stone extraction. Sato conducted a multi-center retrospective study including 645 CBD stones in cases with gastrectomy with Roux-en-Y in 16 Japanese centers, including our hospital, and reported that effectiveness and safety of balloon-assisted enteroscopic ERCP and EUS antegrade intervention were comparable in CBD stone removal. However, complete stone removal after technical success was superior in balloon enteroscopy assisted ERCP. Moreover, in US BD, it is reported that the high technical success rate is associated with high complication rate. So EUSBD in surgically altered anatomy has the advantage that looks easier when the IHBD is dilated. But disadvantage with higher adverse events, US HGS, HJS might be difficult when the space on the intestinal side is limited for deploying a fully covered metal stent. Potential risk of bile leakage into the peritoneal cavity. Difficult in case without IHBD dilation, with right branch obstruction, and with large amount of ascites. On the other hand, balloon-assisted enteroscopic ERCP has the advantage of physiological route and lower adverse events. And disadvantage that insertion through the long limb, inverted view, and lack of an elevator may be difficult to master the procedure. So the reports from Japan recommend balloon-assisted endoscopic ERCP as a first line for CBD stones in surgically altered anatomy, and US integrate intervention and PTBD as a rescue. I want to conclude that EUSBD are now among the treatment options for benign biliary diseases, which are difficult to manage with conventional methods. Thank you for kind attention.
Very well for the enlightening lectures. I'd like to ask the first questions in the US guide biliary drainage for malignant disease that you have quoted here's summary that the complication rate, including pancreatitis, is more than 10%. Seems that is more than usual ERCP complication. Is there any new summary or meta-analysis showing that with the advance of all your instruments, actually this complication would be lower recently? Are you still encountering more than 10%
Yeah.
complication?
Yes. As I mentioned, there are more suitable dilator, or the most important is dilator. The step is most difficult, so I recommend to use the good devices for dilate. And the metal scent is also now several anti-migration metal scent are available.
Okay, so in terms of CDS and HGS, how do you choose which procedure?
Yes, especially in Japan, many doctors prefer to use HGS route because CDS route is unstable, and there are some food impaction, and many cases have duodenal obstruction. So we think HGS is most useful in Japan.
So there's a question from internet. What is your opinion towards US guided enterostomy in surgically altered anatomy? So anastomosis between duodenum and the rulen for access instead of a double balloon or single balloon procedure. So create a US guided duodenostomy to the rulen, like using a lens, and then go through the lens to access the stricture. What do you think this procedure compared to, say, balloon assisted?
I see. Now, in Japan, the use of ramps is very limited, only for one cases. So actually, in Japan, we cannot use. However, I think if we can use that, may be useful.
From our experience, because the ruling is usually quite collapsed, so if you want to puncture with a lens, you need to distend the ruling. So in the literature, some patients may have a PTBD inserted. You can inject contrast with PTBD to distend the ruling. If you don't have that, then you have to insert a needle to distend the limb, but there will be a limitation on how dilated that limb is. So the procedure is usually more difficult and needs to be done by very experienced doctors.
Yeah.
The reason I'm asking is if you're very far up, you have a very long loop and accessing it becomes more challenging. So where do you plan the access point?
So actually it cannot be too far or too close, because if it's too far, then there will be access problem. If it's too close to the exchange, you might be covering the exchange. So usually you need to trace the osmosis and then just slightly distal to that. Yeah.
So in patients with post-surgically altered anatomy, and if they have a hepaticojejunostomia site, benign stricture, post-surgical stricture, so can you can we try some US-guided procedure to manage that such patients?
Yes, maybe I will treat it using balloon enteroscopy first. And if it is difficult, we will try the US guided HGS.
But would you do an HGS in such a patient, because it's a benign disease and there's a hepatogastroscopy site? The other option is doing a PTPD and doing a dilatation of the graded dilatation of the site. Because HGS here you'll have to leave, then I think permanently you'll have to, it would act as a new fistula.
Yes, yes. As you say, PTPD also one of the choice. Yes.
If the CBD is grossly dilated, will you recommend ramps for biliary drainage?
Unfortunately, in Japan, we cannot use ramps for such cases, so I cannot comment.
So, Professor Ryosawa, so when I started doing interventional US, I always thought that CDS is easier done than HGS because, in fact, they are both quite stable organs as compared to HGS, where there's always a chance of stomach migration. But now, just now you mentioned that in Japan you prefer HGS over CDS. So do you have any advice or recommendations for beginners when they are starting to do these procedures? Whether you advise them to starting to do with which procedure and before they move on to HGS. And second is for HGS, I believe in Japan. I want to know in Japan what kind of stents would you prefer as your first choice?
Yes, yes. Maybe for beginner, it is easier to puncture the dilated CBD compared with the IHBD. So if you have a good mentor side by you, you may start from CDS. However, why we Japanese prefer to HGS? We think it is stable. The scope position is stable, and we have many devices for dilation, and so we can perform it easier, we think.
And also a second follow-up question is, how do you choose between an XGS and an anti-grade stent? For example, would it be related to whether you are able to puncture the segment 2073 dot, or maybe presence of ascites or things like this?
Yeah, HGS and anti-grade stenting. I think I prefer personally. I prefer anti-grade stenting plus plastic stent HGS. IT stent. Because I'm afraid the blockage, side branch blockage by the covered metal stent when we use for the HGS. So I prefer to use anti-grade stenting plus IT stent.
So with plastic stents, you are not worried about the leakage?
Sorry?
With using plastic stents for hepaticogastroscopy, you are not
no leakage. Because we don't use electric cautery, so maximal dilation.
So for the person here is one question.
No maximal dilation, minimal dilation. Sorry.
Okay. In the internet asking after the IT stent HGS placement and then removal, how long will be the fistula check remains patent?
We have not so many experience because
So you
it
can
is
remove
for
the RT stent.
malignant biliary obstruction. So we can exchange when it was occluded. We can change it just after two weeks. We can change it.
So you remove it and put in a new RT stent.
Yes, yes.
So how
Right.
long usually it would maintain patents for the RT stent?
Depend on the patient. Some patient occurred in within 2 months or 3 months, and some patient the patency over 6 months.
So if they get blocked, you exchange them, cannulate the site
Cannulate along the stent,
along the site.
cannulate and place guide wire.
Okay, so I think in the interest of time, we should finish this section. So thank you, Ryo-san.
Thank you very much.
So let's go have a tea break, 15 minutes, come back at 10:50. Thank you. In terms of energy devices, there are two devices that are available. The most frequently described one is the radio frequency ablation, and this is also available in Hong Kong and also many Asian countries. The use of microwave needles is still in development. And most recently, the use of a radioactive fluid, which is named as the Oncosil, and pioneered by Nam Nguyen, who is here. We can also use this for ablating pancreatic tumors. So I'll start by EOS-guided pancreatic cyst ablation. So actually, before we ablate the cyst, there has been a long controversy in terms of whether we should or should not be doing this. I think the procedure is pioneered mainly in Korea and actually quite widely done over there. Whereas in the also in some centers in US, they are also doing this. But in the rest of the world, I think most of us are actually not doing anything to the cyst. We are doing FNA, doing some biopsy, but most cysts are not being ablated. So the discussion is whether we should or should not be doing it. Those who are saying yes says it can avoid the need of surgery, avoid the need of intensive surveillance, and the lesion may be completely regressed. But those opponents saying pancreatic cysts should not be ablated says that the malignant changes happen very slowly, and often the cysts, we do not know the exact diagnosis. So we think it's a mucinous cyst, but it might end up turning out to be a serous cyst. And of course, if you ablate the cyst, there's a risk of pancreatitis. Particularly if the cyst has a connection with the pancreatic duct, there's a risk of the alcohol or agent going into the pancreatic duct. So this is the first large study published from Korea. Dong-Wan So, a good friend in gastroenterology, 52 patients in unilocular or oligolocular cyst, indeterminate cystic lesions requiring FNA. The mean diameter was 3 centimeters, mean alcohol volume used was 14 mils. 62% had a complete response, 11% had a partial response, 33% had persistent disease, and mild pancreatitis and splenic thrombosis occurred in one patient. They then published this long-term study in 6 years later, including more patients, showing a complete resolution rate of 72%, partial resolution rate of 19%, and eventually 12 of 13 patients with persistent cysts underwent surgery. Around 10% had adverse events, 1 was severe adverse events, 4 moderate, 11 mild. I think fever, pseudocyst, cystic spillage is relatively mild, but very severe complication including abscess, portal vein thrombosis, splenic vein thrombosis, and also pancreatic duct stricture. In US, they also look at the use of different agents. So they believe that the complications arising from pancreatic cysts was actually due to the use of alcohol. So they use a alcohol-free cyst ablation protocol. So 39 patients with mucinous cyst. One group is alcohol plus paclitaxel. The other group is saline with paclitaxel. So paclitaxel is a chemotherapeutic agent. So one thing to note is that it is very thick. So it's very difficult to inject through the needle into the cyst. You need to use a pressure gauge to put pressure on the syringe to actually push it down, and you need to use a large bore needle. So with this study, they showed that the complete remission rate was comparable between the alcohol arm and the saline arm, but the AE was virtually 0%, both major and minor. So they concluded that the alcohol was not required for effective cyst ablation, and that the use of paclitaxel can reduce the alcohol-related adverse events. I then worked with both of these gentlemen, Dong So, Matt Moyer, and also others, looking at the use of US-guided ablation for pancreatic cystic neoplasm, and we released this positional statement from the Asian US group. Again, 23 statements covering various aspects. So if you are interested, please take a look. We didn't make this as a guideline because a lot of the statements are very, very weakly supported by literature. So it's mostly a lot of expert opinions in this statement. I then move on to tumor ablation. So this is the area where there are more literature supporting the effectiveness of the use of tumor ablation. So most widely published is the use of alcohol injection for neuroendocrine tumor, and one of these are insulinoma. So first of this study was this patient published was a 78-year-old lady, recurrent hypoglycemia due to insulinoma, multiple comorbidities, so surgery was not offered. They used alcohol, 8 ml to induce ablation, and after this procedure, actually there were no further glycemic attacks. They showed that by the use of drugs and also ablation, they were able to reduce the hypoglycemic attacks, and the glucose remained at a stable level. Whereas with no therapy, there were frequent hypoglycemic attacks. So these 3 lines are before ablation. So further, the evidence on insulinomas using alcohol ablation was actually published in 27 patients and 31 tumors. Mean volume size is 13 millimeters. Most of these tumors are quite small. Mean alcohol volume was 1.8 mils. AEs, 5 cases mild and self-limiting. 1 was severe AE, was bleeding from DU. And all described cases had ablation leading to improvement in symptoms and normalization of glycemia. In terms of technique, it's not a difficult technique, so it's very similar to FNA. So this is a confirmed neuroendocrine tumor. These tumors are usually quite small. Right there, you can see it here. So usually very vascular. So if you turn on a Doppler, it will be very vascular. And you can see right there, it's very vascular tumor. And after puncture, so all you need to do is inject a bit of alcohol. You will see some clouding of the tumor due to the fluid being injected. And then you pull back the needle, inject a bit more. You see that alcohol coming out. And then you use a fanning technique, puncture the other side, inject a bit more. So you try not to inject into the normal parenchyma because you don't want to induce pancreatitis. And repeat the puncture until you cover most of the tumor. So technique is very similar to just a FNA technique. So afterwards, I think you can do a contrast study. Okay, so this is a follow-up EUS 6 months later. So the lesion has regressed in size. There's no more vascularity inside. And on CT, the lesion is no longer contrast enhancing. So in terms of long-term follow-up of small pancreatic net, published by Doyon Park in Jan 2018, 34 patients, 54 sessions performed. Mean diameter of the lesion is 10 millimeters, no adverse events. Chronic remission 55%, and on repeat ablation 2 times, 72 increased to 72%. So confirming that it is effective and safe with durable results. But we also look at the use of heat energy to induce a more reliable ablation. So the two available devices are radio frequency ablation and microwave ablation. So RFA and microwave is used quite frequently for a long time in surgery, but in endoscopy, not so common. So the method of generating heat is also different. So if you imagine the microwave at home, when you push the ding ding, so it heats up your whole bowl of water or the instant noodle. So actually it causes the water molecules in the lesion to vibrate, and there's a very uniform sort of heating around the needle. Whereas with RFA, the needle inside has a water cooling system, so it keeps the needle at around 60-70 degrees. So why do we need that is to prevent charring of the needle, so there will be no charring, so that the heat conduction would be very constant. So this is by conduction. So with RFA, the heat is generated from the needle, and then by conduction, it will move towards the side. So meaning it's hottest next to the needle, but less hot in the periphery. So the way to envision it is that you have it's like burning a steak. Okay, so you're cooking the steak closest to the needle is well done, and then you have the steak further away is medium rare. Okay, so if this is a tumor, the medium rare area may still have some viable tumor. So for RFA, you might need to have some overlapping of the ablation circles to induce a complete burning of all the cells. So this is a very old report where surgeons use very big needle, which we use for liver ablation to ablate pancreas. So this was probably not a very good idea because the ablation zone is too big for the pancreas. So in this report, there were 2 patients that received RFA of the pancreas, and they both suffered from severe necrotizing pancreatitis, or even the RFA actually injured the vessels, causing a pseudoaneurysm and hemorrhagic complications. So in surgery, we didn't apply the use of RFA to pancreas. But with endoscopy, so the needle that we use is actually much smaller in terms of the ablation circle. So the most frequent needle use is a 1 centimeter ablation circle. So the distal 1 centimeter is an active, it's the active zone. Okay. So this is the Taiwan StarMed RFA needle. There is another older needle, which is called the Habib needle. It's not really a needle, it's just a wire. So by definition, this is not RFA for me. It's just a diathermy wire. So there's no cooling system in the wire, whereas the StarMed needle has a cooling system. So you need to attach water infusion to the RFA needle to make it stay at a constant pressure. So this is the ablation zone, as I mentioned. So the zone closest to the needle is the well-done zone, and the zone outer, the outer part is the not so cooked zone, so medium rare zone or the rare zone. So of course, with the RFA of needle, we envision that it may be useful for patients with pancreatic tumor. So in terms of ablating pancreatic tumor, again, it's similar to our FNA technique. So you can puncture, the needle is very sharp, but it's a 19 gauge needle. So if the tumor can be seen from the stomach body, it can easily go in, but if it's in the head, sometimes it may be difficult. Of course, we try to stay away from any vasculature because, as you know, if we do RFA for these patients, these are unresectable cases, so we don't want to do more harm. So we stay away, mainly it's for palliation and try to reduce the size of the tumor. We did a contrast study beforehand to look at the microvessels inside the tumor, because after RFA, we can do another contrast to confirm the adequate ablation. So once we start burning, you would see these bubbles around the needle. And there are various settings of the RFA in terms of energy and also time. So in terms of energy setting, nowadays we suggest to start with the low energy. So 20 watts, 30 watts, and then apply it for a longer period of time. In the past, we used 50 watts and it caused burning very quickly. So we feel that with the fast burn, sometimes there may become more complication. And you can see I was repeatedly doing a fanning technique, trying to cover different parts of the tumor. So there will be bubbles covering various parts of the tumor. And then we repeat this until the tumor was mostly covered. And then finally we do a contrast and we inject synovial and so there is not much contrast enhancement. So this confirms a complete ablation of the lesion. So this first study published by Marc Barthé in Europe. So for neuroendocrine tumors and also pancreatic cyst. So their choice of pancreatic cysts are those cysts with neuronodules. So not just a cyst. So neuronodules, but a patient do not want surgery or they choose not to, so they would ablate the neuronodule. For neuroendocrine tumors, significant response is 71%, and at 6 months follow-up, and at 12-month follow-up is 85%. And for pancreatic cystic lesion, disappearance, significant response is 64% at 6 months and then 70% at 1 year. This meta-analysis published in 2020 looked at 13 studies, 165 RF procedures, included both locally advanced pancreatic duct adenocarcinoma and NET. Technical and clinical success rates were high, but adverse events rates were around 15%. Most of them are pain. Most of them do not have pancreatitis because we are ablating the tumor site and not the normal pancreas. So we try not to be too aggressive, actually. So this study demonstrates it's safe, but what we really need to know is whether it's effective. So because these patients are palliative patients, we want to see, apart from chemo, adding RFA would provide a survival benefit. In this study, they published by Napoleon Bertrand from France. They included 100 patients with 104 neoplasms, 64 NETs, 23 were metastasis, and 10 with IPMN with neuronodules. 60% had complete tumor response, 31% had partial response. And on multivariate analysis, the presence of NET and a small sized neoplasm were independently related to complete tumor ablation. So this is one message. So the choice of patients is important. And in this other retrospective comparative study, looking at RFA ablation plus chemo versus chemotherapy alone. So in the chemo group, the mean maximal diameter significantly increased. So without RFA, the tumor increased in size, whereas in the RFA group, there's stable size. And in the RFA group, it was also able to reduce the mean narcotic pain drug dosage, so reduce morphine, but mortality is not significantly different. This other study is also interesting, looking at RFA versus surgical resection, published by Stefano Crino, my good friend again. In CGH, they did a propensity score analysis. They matched the patient. Adverse events rate, of course, significantly less than surgery, because in surgery you are looking at enucleation or distal pancreatectomy, or even sometimes Whipple. Severe AEs, 0% versus 15%. Clinical efficacy similar. Mean duration of follow-up was a bit shorter in the RFA group. Hospital stay, of course, significantly longer. But RFA group, we had almost 17% recurrence. Of course, they can again have another RFA or surgical resection. So this is the Kaplan-Meier curve of relapse-free survival. So expect around 15 to 20% failure rate. Okay, but of course we can then give them another RFA, which is relatively low risk again. This is from Creo. So we know Creo makes a lot of microwave devices. They're more famous for the ESD device, but this is a microwave needle. This is still in experimentation. So again, similar to RFA, the needle can go into the liver, puncture the liver, going inside right there. You can see the needle, and then burning the liver will cause some bubbles. And the idea is the ablation may be more uniform, but this is still to be proven. OncoSeal. So I think Nam should be talking about this. So this is a very interesting device. It's a device, okay? Because it's an injectable radioactive fluid. It can deliver up to 100 grays into the treatment tumor. Before the treatment, you need to calculate the tumor volume size, because with the larger tumor, you need to inject more agent. With a smaller tumor, you need to inject less. And most of the radiations is delivered within 3 months. So this is NAM's protocol. So we give chemo for 3 weeks, followed by the injection of OncoSeal. So the idea is for OncoSeal to replace radiotherapy. So the benefit, of course, is it's a single injection. So the patient does not need to come back for repeated radiotherapy. There's a minimal toxicity to surrounding tissue, but maybe only in Australia you can afford it, because it's covered by government. In Hong Kong, it's still difficult because it's very expensive. So this is from NAM. This is a 63-year-old lady with obstructive jaundice, 3 centimeter mass in the head of pancreas. This is the P32 solution. It needs to be covered by a special perplex cover because it's radioactive. Okay, so you cannot use your bare hands to touch it. And you need to ask the radiation oncologist to come to do the injection. In terms of techniques, it's similar to FNA. So you just puncture, inject the solution. For larger tumors, you need to do it in sequential. So first half and then second half, and then special care is you cannot get your scope contamination because you can cause your scope to have radiation. So right here now was flushing the needle with a lot of saline to make sure all the oncoseal has been flushed out and there's no risk of contaminating your scope. Because once there's contamination, the scope you cannot use. For how long? 6 months? 1 year? 3 months. Okay. So I think for the PANCO study, NAM was able to show that the patient with a stable disease control was up to 70%, and surgical downstaging was possible in 25%, and all underwent Whipple's operation. So promising device. So in conclusion, there are many new interesting ablative procedures available. But we really need more data from RCT to confirm the efficacy. So thank you.
So what is the role of radiofrequency ablation as a first-line therapy for insulinoma? There are some guidelines which now recommend it for small, if there's a small insulinoma less than 2 centimeter, it can be also used as a first-line therapy compared to surgery.
Yeah, so it's a very big discussion. So first, do we need to treat it? Because NET, we know there are several grading, grade 1, grade 2, grade 3. So grade 1, there are a lot of people saying it's almost benign, you don't need to treat it. So this is one controversy, and of course we have several options. So if you want to treat it, so you can use surgery, which is enucleation, or endoscopic ablation. So you have two choices, alcohol or RFA. So we don't know which is better, but of course alcohol is super cheap. So if it doesn't work, then of course you can use RFA. So we don't know.
How frequently use PD stenting before or after?
So from the studies, if it's less close to the PD, like within 1 millimeter from the PD, there's a risk of heat energy injuring the pancreatic duct. So then in those cases, you do a prophylactic PD stenting.
Would you ablate an insulinoma in a surgically fit patient?
So of course you can discuss with the patient. So I think it's pros and cons which you can discuss. But I think if the patient doesn't want surgery, ablating beforehand and then doing surgery as salvage is also an option. Okay, thank you.
Multiple NETs in pancreas, probably.
Multiple NET. Yeah. So probably. Yeah. In those patients, maybe surgery is a better option.
So thank you very much, Dr. Teo. So next we have Dr. Raymond Tang, who will talk about EUS-guided celiac access neurolysis / celiac ganglion neurolysis with one. So I'm sure Raymond needs no introduction. He's an assistant professor in the CUHK and also the deputy director of our endoscopy center. He has published extensively and is now running an RCT on EUS London University's cut for difficult RCT. And today he will talk about celiac praxis neurolysis.
So thank you, Shannon, for your kind introduction. So I think my assigned topic is a very practical one, and I think there's still a lot of discussion about which procedure is better. So let's see what we know so far. Now, pancreatic cancer pain is a real problem. I think really it's a quality of life issue for our patients with advanced cancer. Now, 80% of patients with advanced cancer of the pancreas have severe pain. And pain is really due to invasion of the adjacent nerves, destruction of tissue, and even invasion of the organs. So this is an important aspect besides just doing a procedure. So here's a tumor, and clearly it involves some, like celiac plexus there. No, so management of cancer-related pain. So a lot of times we will resort to opioid type analgesics, but then side effects are problems. So it includes drowsiness, constipation, nausea and vomiting, and also sometimes confusion. Now, local pain control options include CPN or CGN. So we really hope to improve the pain control, reduce opioid consumption, and plus or minus also side effects from systemic medication, and also improve quality of life. Now, traditionally, this CPN is offered by anesthesia colleagues, and so it has a long history. So the first one was performed in 1914, and this is what was happening. So it's a posterior approach. It could be done with fluoroscopy or CT guidance. Basically, we use a needle through the posterolateral area to L1, and now the concept of walking the needles sometimes make us kind of wonder how this really works, but it seems like it so far it's actually working really well for our colleagues. And the interesting thing is if aorta is penetrated, the trans-aortic technique can be applied. But I probably won't go into details of this. So some data on percutaneous CPN versus analgesics. So you can see that. CPN definitely has advantage for some pain control there at 4 weeks. Okay, now, so here is the, okay, let me go back. Can I start the, I couldn't start the video actually. Oh, can I just? Oh, actually, I have my slides. Or can I use my slides? So sorry about the technical issue, but I guess we can just go with the slides here. So as you can see, the two major landmarks we want to show here is, we are below the OG junction with the scope, and then you can see the abdominal aorta and the takeoff of the celiac artery. So, but with this view, I will also ask you to pay attention to where the diaphragm is. Because we obviously don't want to, inject something into the diaphragm. So let me see if I can, I'll show you the video here. So, okay. Oh, maybe this is not the video part. Okay, okay, sorry. Oh, maybe I'll just go with it. So, okay, the video is actually after this. Sorry. Okay. Maybe I just. Okay. Sorry about the technical issues. Sorry. So early meta-analysis actually give us some idea on how this is performing for the patient. So in this early meta-analysis, so the pooled proportion of patients showing good pain relief is up to 80%. And for techniques, for CPN, we can do it by the central or the unilateral approach or bilateral approach. And also, there's also a report on gangliolysis and also the concept of broad plexus neurolysis over the SMA area. Now, this is the central approach here. So now, so we have a clear identification of takeoff of the celiac artery. So now the needle is in, and we're targeting the base of the celiac artery takeoff. And we'll first inject 0.25% of bupivacaine, and followed by injection of absolute alcohol. So at this juncture, you'll see a snowstorm appearance on the US view. So, and this also indicates that the alcohol is being injected there. Now, but later on, we'll come back to this kind of snowstorm effect when we perform a bilateral CPN. So now at the end of procedure, we should monitor the patient for drop in BP because this can be observed after procedure, but it can be managed with IV fluids. Okay, so now what about bilateral approach versus unilateral approach? So for bilateral approach, it means injecting alcohol into both sides of the celiac plexus. So from a technical standpoint, so once we identify the takeoff of the celiac artery, we can rotate the scope a little bit clockwise or anti-clockwise, and that will be kind of the area we will perform the injection. But you can imagine that after the first injection, the views probably will be less good, and then it will be more difficult to do the second injection. So now, there's a study from Professor Sahai, and this is a study of 160 patients, so comparing central versus bilateral approach. And he can demonstrate that the bilateral approach is more effective and with pain reduction up to 70% of patients. And for adverse events, so one patient has self-limited bleeding, so it shows us that basically the bilateral approach is feasible with good results and also acceptable risk profile. Now, so again, in another study by Dr. LeBrown's group, so 50 patients, and actually, now interestingly, there was no difference in the onset of duration of pain relief or the safety signals or survival. Now, later on, we'll come back to the concept of survival in the RCTs for use-guided, CPN or CGN later. So for broad plexus neurolysis, you can see that the plexus actually doesn't just appear on the superior part of the celiac artery takeoff. So actually, it really goes around the SMA also. So for broad plexus neurolysis, we can use a 25 gauge needle to inject a neurolytic agent. Now this time, probably will need some contrast to show us where things are. And to both sides of the SMA. And in this study by Sakamoto's group, so after the procedure, they would perform CT to see where the agents were injected. So this is to tell us where exactly things were targeted. So here you can see that they did a very meticulous job in mapping out which area was treated. So now there are two groups. So the regular CPN group and also the broad plexus group. And you can see that the broad plexus group had more patients with 6 contrast-bearing areas. So it seems like it was more broadly covered here. And then these patients has better short-term and long-lasting pain relief than patients with less than 5 contrast-bearing areas. Okay. Now, so what about CGN? So now, I think with EOS, we can do very targeted injections. I think this is always an advantage. Now, let's talk about the celiac ganglion a little bit. Now, this is often a small and kind of like a vague cloud looking like a structure. So sometimes it's hard to look for, but if it's present, it could even look like a chain of ganglion there. So usually you look for it above or alongside or below the celiac trunk or even at the SMA takeoff. Now, so it can look like this. So so there is report on direct ganglia injection into as many visualized ganglia as possible. So I think the logic is we're trying to hit the the ganglion itself instead of the nerves, and there's chance of using less alcohol when we do CGN. So now here from a ganglion that's bigger than 1 centimeter, this study talk about injecting at the central point, and for ganglia that may be bigger than 1 cm, we can also actually inject into the deepest point and then slowly draw back. So I think there's a typo here. I think the first one should be less than 1 cm. Sorry about the typo. Let's look at the case of CGN here. Now, this patient actually now has a ganglion being identified here, now really near the takeoff, but not directly, at the superior part. So once we see a ganglion, so we slowly advance the needle into ganglion, and then and start injecting a little bit of bupivacaine, and followed by alcohol injection. But in this case, the amount of alcohol injected was definitely less than the usual amount I use for CPN. So this is absolute alcohol injection. Again, you see the snowstorm. Okay. So now, so for CGN, so in this retrospective study, so first of all, I think it's well accepted the ganglion may not always be seen, but in this study, at least 62% of patients will have a visible ganglia, and for about 50% of patients at week 1 already had a symptomatic response. And so for patient visible ganglia, so they were 15 times more likely to respond to the celiac-guided pain control. So now what about CGN versus unilateral CPN? So now in this study by Doi and colleagues, so it included 68 patients with abdominal pain, with almost all from pancreatic cancer. Now, so it's very encouraging that 88% of the time the ganglion could be visible. And then you can see that actually there's better pain relief in the CGN group, a little bit more than 70% versus only 45% in the conventional CPN group. Now, I think we're actually having a lot of hope, for using more CGN, after Doi's study. But then suddenly in 2019, there was this study from Professor Lavi's group published in CGH. I think it brings us, kind of more questions than answers. So, so this is a big RCT with more than 100 patients. So what they are comparing is CGN plus CPN versus bilateral CPN. So, and interestingly, what we see from the study is that while there's no difference in the rates of pain control, now I would point out that the pain relief percentage is a little bit lower than in the other studies report you can see from Doi's study. So the pain relief was at least up to 70%, but here both arms showed less than 50% response. And what actually people feel kind of puzzled was the median survival time was significantly shorter for patients receiving combined CGN and CPN. So at 12 months, somehow there's a lower survival in the CGN group. So I think we're still not quite sure what led to this observation, but I think the author is trying to explain it by perhaps some kind of inflammatory response was triggered that may not be favorable for treatment or the course of the tumor, and somehow the degrees of the disease become more aggressive. But I think so far we don't have a concrete explanation yet. So what about the timing of CPN? Now, I think there are more and more studies talking about, is there a role for earlier use of EOS-guided CPN, than waiting till for failure of the traditional pain management. So, and by definition, in this study published in 2011 by Wesley et al., so early CPN means performing at the time of EOS-guided tissue acquisition. And you can see that early CPN provided greater pain relief compared to the conventional therapy at 1 month and also at 3 months. So now, probably it's hard to get data for more than 3 months because we know that sometimes the pain can come back in about 3 months' time. So, and now morphine consumption was similar in both groups at 1 month, but trended towards low consumption at 3 months in the early group. You can see that from here. Now, what about other techniques or other forms of ablation of celiac ganglion? So, now, this is from the Shanghai Hospital in Shanghai. And we can see that they have a lot of experience with using iodine 125 seeds for US-guided celiac ganglion irradiation for pain control. And this is a prospective pilot study, include 23 patients. So these seeds were implanted into the ganglion, and 2 weeks later, you can see that the BAS score and the mean energy consumption is significantly less than the preoperative values, and there's no procedural deaths or major complications. Now, this study is actually a follow-up study with some long-term results from the same group, and so we can see that they have 43 and 48 patients. So this is a comparison between CPN and iodine 125 irradiation. So you can see that postoperatively, the VA score was significantly lower than the preoperative levels in both groups. But again, here at 1 week, so 60% of patients in the CPN group achieved partial relief, while no patients in the EOS, the guided radioactive seeds group experienced pain relief. So, and however, over time, at 4 weeks' time, the pain relief is actually better in the radioactive seeds group. So you can see from this table here, so initially the immediate response is probably better with CPN, but then over time, eventually the irradiation group will catch up. Okay, and also from Dr. Hobbs' group, and so Dr. Bain actually also reported on the use of a very thin RFA catheter for ablation of the celiac ganglion. And so now I would point out to you that this is not the StarMed RFA device. This is the very, I think it's the very thin 1 French heartbeat probe that we used to know that can be inserted through the needle. So this is quite fragile probe. So, but again, in this study, including 14 patients in the CPN group and 12 patients in the LFA group, so we can see that actually both groups you have some reduction in the pain score, and you can see that like for the RFA group, seems like it's performing a little better. So, and also with the RFA group, it seems like there's less severe GI symptoms. So I think this is something that may come back later. So we'll keep an eye on for new technologies for EOS-guided pain control. But again, we should still remember there's still some limitations of the EOS-guided approach. Now, sometimes landmark could be difficult if patient actually has a big tumor involving the takeoff of the celiac artery. And sometimes patients have prior CPN already, and the landmark will be a little bit blurred. And if the patient is really cachexic, then there's very little soft tissue space between the gastric wall and the aorta, and also the diaphragm. So sometimes it could be difficult to inject. And also some aberrant vascular anatomy that we have to watch out for. And also, again, ganglion may not be always visible. For adverse events, no, I think there are some mild adverse events that we may encounter, but obviously there are also some more rare, severe events. So for mild events, now we may see transient hypotension that can be managed with IV fluids. Now diarrhea actually is also relatively common, and sometimes there's a paradoxical increase in abdominal pain after procedure, but in general, things tend to subside over time. Now, the severe adverse events that we kind of dreaded about, luckily is rare, but again, structural laceration or ischemia-related complications from vascular injury, or even thrombosis of some major vessels, or even neurological damage from spinal cord infarction, sepsis. These are things we want to watch out for. And also, can we do repeated CPN? No. So if the patient survived long enough, sometimes the effect of the CPN will wear off, and probably around 3 months' time, we may, see some return of pain. But again, so there are some early reports also talking about the feasibility of this. And yes, so it could be done. And but again, we don't know, how many times we can do this. I think the really, whether we can do this over time depends on whether the landmark is still clearly seen. So I think I will leave this topic like that. And so in conclusion, for US-guided celiac plexus interventions for pain control, I think we have quite a lot of evidence. It's safe and effective. Now, today we focus on cancer-related pain, and we're not talking about pain from chronic pancreatitis. Now, for US-guided CPN, it's very well established. We have several techniques for this: the unilateral, bilateral, broad plexus neurolysis technique. And CGN, I think there's encouraging data about better pain relief, but again, we're still puzzled about why the survival in the combined CGN CPN group is not good. But I guess if you're really thinking about doing CGN, maybe you don't need to combine with CPN. So, and early CPN seems to be a better option than waiting for medical failure. So thank you very much.
So are there any questions on the floor?
Raymond,
Yes.
thank you for an excellent lecture.
Yes.
Can I just actually ask your opinion on two things?
Yes.
First is actually early timing.
Yes.
What do you mean by that? Should we do a block for all patients with newly diagnosed as cancer, or wait until they have the first sign of pain and do it? That's early. And the second is actually the volume of alcohol that we can inject.
Right.
And thirdly is factor that's actually predict response.
Yes.
My experience actually, if I see the direct tumor invasion to the plexus, 100%, none of them actually respond. Doesn't matter how much actually you find. Compared actually to those that actually have best response when they don't have any invasion and they have immediate pain relief. So if they walk up with no pain, those patients respond really well.
Yes.
Just one more.
Yeah, so thanks, Nam. So these are all good questions. Actually, maybe I actually start with the replying to the second question first. So I think evaluation of anatomy before the procedure is really important, because if we see bulky tumors pretty much touching the aorta, I think there's a good chance that we may not even find a window. No, obviously, we probably shouldn't inject alcohol really into the tumor just in hope we get to some nerves there, but probably not a good idea. And the result probably will not be very promising there. So that, I think we had similar experience. So probably I would not suggest that. While this could be disappointing a patient that we don't have window, but maybe still it's better not to cause more trouble than, But for the first question, yes, so I think it's also a good approach to ask the patient about the pain control, maybe at the time of the tissue acquisition. No, I'm not talking about tissue acquisition for potentially resectable tumors or tumors for downstaging, but I'm probably talking about clearly advanced disease, inoperable disease. And sometimes the patient may not tell us voluntarily. Sometimes we need to explore that. So I think if they talk about, okay, I couldn't sleep well, or I'm not doing the usual daily activities that I'm doing, and I see that as the pain from the cancer is impacting their life. So I have a lower threshold to treat either by medication or the procedure, EOS-guided CPN. So this will be the time I will try to think ahead, but I think what early is early, I think it's hard to say, but if I take the opportunity, at the time of tissue acquisition, I think I will kind of explore it if it's not well documented in the history. So.
Can I ask a question? So most of the data regarding EUS guided or this CPN is about the pancreatic malignancies. But can it be used for other malignancies, for example, other periambular malignancies and carcinoma gallbladder? Because I repeatedly receive requests from departments. I saw some data, but what is your take on it?
So I think that this also goes into kind of, can we have a broader, indication for this? Now, I may also ask Anthony and Shannon's opinion, because they see some, upper GI cancers that can often cause pain in this area. So maybe I seek their advice here.
So I think in terms of disease etiology, the pain is caused by infiltration of the celiac axis nerves. So if you accept that theory, then it should work for all kinds of tumors, right? As long as it has infiltrated the nerve. So theoretically, it should work for all of these etiologies. The problem with CA stomach most of the time is that the pain, you can't differentiate whether it's from the primary tumor or from the invasion, right? So sometimes, and also the stomach cancer itself may occlude the window for the procedure. So for gastric cancer patients, you will need to have a good expectation management for the patient that the procedure, you can do it, but may not work because of the tumor pain, maybe from the primary tumor itself.
Pancreatobiliary, I'm talking about gallbladder malignancies particularly. They are very painful. The pain is very significant, and theoretically it seems to be conducted by the celiac plexus. But I have never, the data is very limited about it.
It works very well for gallbladder cancer. For gallbladder cancer, we've done it, and it works well for gallbladder cancer. But the lasting effect is less than 4 weeks.
Yes, please.
Regarding CPN. I once heard some parties describing that we could do it without the use of bupivacaine, and that the use of simply injecting alcohol and that inducing pain in patient would reflect that the procedure may correlate to the success in treating the pain afterwards. What is your opinion on that? And also the dilution effect of probably it would dilute the alcohol if we get bupivacaine.
Yes. So these are all good questions, and I think the bupivacaine probably is mainly for patients' comfort. Then really is it making the overall pain control better? I think it's the short-term thing, because sometimes we see this if we do direct ganglion injection without the bupivacaine. Not all patients, but some patients may say they have paradoxical increase in pain. So it's possible. I think conceptually it can happen because we are ablating something. So, but I guess this is my personal experience. So how I see that part of bupivacaine injection is, for example, if I have someone really cachexic, the space between the stomach and the celiac takeoff is really narrow. Then with the bupivacaine, it's kind of like doing ESD, right? I create a cushion, and then so I expanded that space. So later on, actually, it helps me to have a better target when I inject, say, 10 mL of absolute alcohol. Now, of course, if you don't have a lot of space, I won't really insist on injecting, say, 10 mL. But I think if I can regenerate some space, hopefully, I have a better target, and that's kind of my personal experience. It may be helpful. So.
Okay, so thank you very much, and thank you, Raymond. And so our next speaker is Professor Sudipta Chowdhury. I hope I pronounced your name correctly. He is the professor and head of the Department of Gastroenterology from the Christian Medical College from India. And he has 17 years of research in gastroenterology and endoscopy, together with 18 indexed publications and 5 book chapters. He is very experienced in the EOSGE procedure and also in the EOS guided gastric So today he will give a talk on these two.
Thank you, Shannon, and thank you, Anthony, for the invitation and the warm hospitality we've received so far. Thanks a lot. So I'm going to talk to you on EUS-guided gastroenterostomy and how I do it, because there are many ways to do it. As they say, there are many ways to skin a cat. So if you look at it, gastric outlet obstruction is an often encountered problem in gastroenterology, and traditionally we had been using the duodenal stents for relieving it, and surgeons have been doing the gastric jejunostomy. Now, as time went by, endoscopists tried to explore this area, and as early as the 1980s, and Fisher Evans tried to do the through the scope suturing and tissue approximation with the US control. Subsequently, there was a development of a flexible endoscope and a compression button to do the gastroenterostomy. This interesting paper came in 2007 from China, which showed a transgastric endoscopic gastroenterostomy using a partially covered occluder in a canine model. But the game changed extensively in 2012 when Ken Binmola and Janak Shah published their paper of using an axial stent to do a US-guided gastroenterostomy. And since then, there has been a flurry of literature, more data coming on the feasibility and the safety of US-guided gastrostomy. And after multiple studies, actually you have a meta-analysis, and 7 studies, meta-analysis of 513 patients showed the clinical success of EUSG is higher as compared to the duodenal stent. Technical success doubtful. Serious adverse events are lower, stent obstruction is lower, reintervention rates are low. I don't know why it's coming as a question, but it's basically equal. Clinical success as compared to USG and surgical gastroenterology should be equivalent. It's not question mark here. And of course, the technical success was slightly lower than surgical gastroenterostomy, but serious adverse events, stent obstruction and reintervention rates are equal. It shouldn't be question mark. And length of stay was lower with USG. But now we have this fantastic study from Professor Teo's group, which came in Lancet and showed that the reintervention rates were lower with USG as compared to duodenal stent. Stent patencies were lower. 1 month gastric outlet obstruction score was better with the USG. However, technical success, clinical success, no difference. Death at 1 month, no difference, and quality of life, no difference. So obviously, USG scores quite above the duodenal stenting. Now, what are the indications? Most common indications is gastric outlet obstruction, afferent loop obstruction, US-directed transgastric ERCP in patients who have had a Roux-en-Y gastric bypass. The contraindications include cancer involving the body of the stomach, fourth portion of the duodenum or jejunum, if there's a large volume ascites, and for our center, which we use is when a life expectancy is less than 3 months and an ECOG score of less than 3. Now, I'll just go straight to the technique and how I do it. There are multiple ways of doing it, and was initially described as doing a direct puncture. Then they had described a technique when they're pushing in a balloon into the second or the third part of duodenum and puncturing the balloon, putting in a guide wire and using the guide wire to access the duodenal loop. And this is, of course, one of the better techniques which Professor Theo used in his study, the EPAS balloon, having a double balloon with a central feeling catheter and using this as a access point for doing it. Unfortunately, back in India, we do not have the EPAS balloon, and so I do it in this technique, and what I do is I use a feeding catheter, which can be a nasojejunal tube, a nasobiliary drain into the second part of the duodenum, fill it up with a contrast and methylene blue, direct puncture with the axios, and deploy the stent. So this is how we do it in our center. So for us, what we need is the coagulation tests are to be normal. Albumin, we prefer to be around more than 3. And the reason was that this is, again, we borrowed it from our surgical colleagues when they said, most of our referrals come in from the surgeons and they insist that please have the albumin more than 3, otherwise there's a high risk of leakage. I do give antibiotics. I was just talking to Professor Teo yesterday, and his center, none of them receive antibiotics, but I've been doing antibiotics. So I probably have to change my practice as regards antibiotics are concerned. And I do give them high-dose PPIs. So one of the most key steps is, of course, preparing the stomach. And as you know, most of these patients have gastric outlet obstruction, tend to have a lot of food residue. And we keep them fasting for 8 to 12 hours, put a nasogastric drain, and keep on washing the stomach. Despite that, many a times we go back inside and see a significant amount of food residue, and we have to cancel the procedure. Of late, what we have been trying to say is put them on a liquid diet for for at least 48 to 72 hours before the procedure. So this is how we do. This is one of the patients where we had to do it, and this is a lady who had a pancreatic cancer, had a ERCP and a stenting done, and subsequently came in with a gastric outlet obstruction. So here you can see we are placing in the nasobiliary drain over the, I'll run it. Just, how do we access the bar? Oh, okay, on the screen. Oh, lovely. Thank you. So I'll just move it forward, and as you can go. So here we can see we can put a guide wire across it and then put the nasobiliary drain across the guide wire into the D3 and D4 portion of the duodenum. The second part, of course, starts with identifying where do we make a puncture. Now, ideally for my practice, I've been trying to puncture the D4 segment. And I don't do a jejunostomy, I do a duodenostomy, gastroduodenostomy. The reason is, again, we do not have a pus balloon. That portion is relatively fixed. The DJ flexure is a fixed structure. It's there in everyone. Just left side of the lumbar vertebra, you can see the DJ flexure very easily. If you follow the left renal vein and the left renal artery, and you torque the scope on the clockwise direction, you will come across the DJ flexure coming up. So that's an easy way to do a landmark assessment. So as you can see, this is how we do it. And so what we do is look at the kidneys and, and you can see here, so that's the DJ flexure and the previously placed guide wire. You can see, and you can use the fluoroscopy to confirm the position. And once you've confirmed the position, what we do is we start filling the loop with just normal saline. We do not use contrast at the beginning. We just start to fill up the loop with saline. That's primarily because that helps us identify that we've got it correct and we are in the right position as such. So just run this video a bit faster. So keep on dilating till we get a good amount of dilatation of the bowel. And as we keep on doing, you can see the previously placed guide wire, the nasobiliary drain there, and you can see a decent amount of distension of the bowel. Now, at this point, we administer an antiperistaltic agent. Now, there are multiple antiperistaltic agents. The one that we have is hyoscine or buscopan, and the onset of action is 85 seconds, duration lasts 21 minutes. The other thing is glucagon and IV glucagon. 1 milligram onset of action is 65 seconds and duration of action is average of 23 minutes. What we do use a combined injection of both buscopan and glucagon, getting the advantage of early and a longer duration. So the onset of action remains at 65 seconds and duration of action is around 30 minutes. So we have a fairly long duration of gut wall distension and stability. So once we have this contrast, we start injecting methylene blue and a contrast in methylene blue and dilate it further. Now, early on, I was to use something called a finder needle. I'll use a 19 gauge needle just to puncture the loop and make sure that I'm aspirating contrast and methylene blue. That's just to make myself comfortable because, again, not having the EPAS balloon when we are doing it, we are always scared that there's a colon also out there and the high risk of creating a gastrocolic fistula. So once we have, and we try to get a long axis of around 3 centimeters, because that's what we are trying to do is deploy a 20 millimeter axis. So then we put contrast and see the loop very well distended, keeping on filling the loop again a bit more until we get us a long axis of around 2.5 to 3 centimeters too. This will continue. I'll let it run. So once we have a good sized distance of around 3 centimeters, we know that we are ready for the axial deployment. And the axial deployment is straight on like in any other case, like you do a cirrhosis drainage or a gallbladder drainage, nothing really different. And once we deploy the axios, pull it back. And the biggest relief is to see the gush of contrast and methylene blue coming out of that after deployment. And that actually makes you confident that you made the puncture. So, and there you can see a good amount of thing. After this, what we do is we usually take an upper GI scope and inject contrast through the axials just to confirm that we are in the right position and the right tract. Now, this is how we do it at our center. So again, you can see the small bowel loop. So we inject a little bit of contrast through the scope and just to make sure that we are in the right position. So that completes the procedure, and that's about it. And the following day, when we do the CT, we always do it with a contrast CT CT, and just to make sure that we have got it in the right position. And as you can see, the axios is actually bridging across the stomach into the small bowel. So the advantage with the USGJ is that you can combine it with an alternate procedure. In people who have combined gastric outlet as well as biliary obstruction, it's a very good technique to do both a USGJ as well as a HGS. And when you have a combined obstruction, it's ideally better to do actually you should only do a USGJ and then only try an HGS, because if you do not succeed in getting a gastric drainage done, then the patient ends up having large volume of bilious vomiting. So that can be a challenging problem. So this was again a 50-year-old gentleman who came in with pain, progressive jaundice and vomiting, had a cancer which was obstructing both the duodenal lumen as well as as a result of which had extrahepatic biliary obstruction. Again, in this patient, we proceeded with doing USGJ, standard one. And this was followed by hepaticogastrostomy. And this combined procedure took around, with exchange of scopes, exchange of accessories, took around 1 hour 15 minutes. So the advantage with this, compared to what you do a triple bypass in a surgical setting, the morbidity with that procedure, this is a relatively easy procedure, I would say, compared to that. And the relief is instant. So this is, again, I'm not going into it. Professor had already discussed very beautifully about how to do an HGS. So this is just doing the HGS, and that completes the procedure. So in the same patient, you can do both a USGJ as well as an HGS. The other indication for doing it as commonly is an afferent loop obstruction. Now, the afferent loop obstruction is found most often in a post-operative setting. The advantage with an afferent loop obstruction is that the obstruction is relatively fixed. The bowel loop is quite distended. You can puncture it with an axial straight on and get a good drainage. So this is a lady who had a surgery Whipple's procedure done and then came in with an afferent loop obstruction. And here you can see a grossly distended loop of a small bowel and the MRI alongside it. So here again, the same thing, get the axios in. And like in any other axios deployment, pull it back, intrachannel deployment, and then we have the axios coming out. So this gives a very good instant relief. The bilirubin comes down within 24 hours and the patient has symptomatic improvement. But the afferent loop is a relatively fixed structure, and sometimes you may actually do the procedure even with a long stent, any long covered stent. In fact, in 2016, we showed how to do it with a Nagi stent, actually, in a young man who came in with an obstructive jaundice because of an afferent loop obstruction. So here was an afferent loop obstruction, and we did use the Nagi stent. And the Nagi stent, I'm just running through this. So using a Nagi stent through the wire, we deployed the Nagi, and the patient had symptomatic relief. Now, what I wanted to show you is that even in afferent loop obstruction, the anastomosis that we obtained with that Nagi stent itself is good enough. This patient came back to us after 5 months, when he was a bit stable, was taken up for a definitive surgical procedure, and intra-procedurally, you could see a very good anastomosis between the stomach and the jejunum. So the surgeons actually had to, surgically. This is the level of anastomosis that we could achieve only with a Nagi stent between the stomach and the jejunal limb, showing a very good anastomotic function of these things. Sorry. So the complications that we faced most commonly with USG has been maldeployment, bleeding, and gastrocolic fistula. Maldeployment are 4 types. Type 1 is when we accidentally leave it in the peritoneal location. The type 1 can be managed very effectively by pulling out the stent and closing the defect with an Ovesco or sometimes a simple clip, because it's just a 10 French hole out there. The type 2 is when the perforation happens when there's a cautery burn of the jejunal limb, but the stent is still deployed intraperitoneally. In type 2 bleed, if there's not a major leak from the jejunum, most of this can be managed with just pulling out the stent and redeploying the axios. The problem happens in the type 3 when the stent actually slips beyond the stomach wall and lies in the peritoneum with the distal flange inside the lumen of the jejunum. As a result, a type 3 can lead to significant contamination of the peritoneum or the retroperitoneal space and can be significant. The other is type 4, which is accidental deployment into the colon leading to a gastrocolic fistula. This can be also managed effectively with just an axios with an Ovesco. So the long-term conclusions have been stent occlusion and stent migration, and what we have been doing in our center have been this technique of direct EUS-guided puncture of the jejunal limb. Thank you very much for your patient hearing.
So maybe we can take some questions about EUS-GE before...
Yeah, there are 2 different topics.
Yeah, before we talk about the GE management. So is there any question from the floor?
Have you used it for benign conditions?
No. Not as yet, no.
So actually for us, we do the EUS-GE for SMA syndrome. That is the only benign indication that we do it for. Because for SMA syndrome, we all know that after the patient gains weight, then we can pull out the stent. And after the stent is removed, the fistula actually heals itself. So it's a temporary condition that can be reversed with the EUS-GE. And the beauty is the patient does not have to have 2 tubes, one an NG, one an NJ, when the patient is struggling with nutrition. So I guess the quality of life is much better for the patient. But if you're talking about like caloric stenosis or peptic strictures leading to GOO, that's a different matter. Because the thing is, even if you're able to achieve an EUS-GE, which technically is the same as for living tumors, the problem is for these, even if we go in for surgery, there are 2 things we need to do. One is a vagotomy, which decreases the gastric axis secretion, right? And the other is a GJ. So the EUS-GE can only replace the EUS-GJ bypass portion. For the anti-reflux part, the patient would probably need to be on long-term PPI. And also with the problem with the hot axios, I know there are Boston cells sitting at the floor, but they will tell you that it's a fully covered stent and it never revolts, but it does. It has been reported in the literature. So if you intend to do this for benign indications, the patient will need the stent to be replaced every year. Or else there will be stent erosion, and because the covered part just wears off, and then it becomes an uncovered stent, and then it gets granulation tissue. So if you are to do it for like benign indication for whatever reason, you have to warn the patient that they will need to pay for the stent again every year.
Can't you just remove the stent and the track has matured, it would just stay?
Well, so far the evidence is the track usually heals. So I'm not aware of any data that if you remove it after 1 year that the fistula track will be patent. So we probably will need to do more studies on that, but this is the current available.
The track closes.
So I have one question for Professor Siddipal. So you mentioned in your lecture just now that if you tend to puncture the DJ flexure, which is like a relatively stable
Position.
And therefore for tumors invading the 4th part of the duodenum, it's a contraindication
For me, yeah.
So if you do have the E-pass balloon, would you think that a GJ would actually be
I think the EPAS balloon has been the game changer in GJ. Unfortunately, we do not have it, but the more I've seen it and I have watched the videos, I think EPAS balloon is the way forward. Now, the thing is that it gives you a fixed structure. You have two fixed anatomical, targets, the two balloons and the fluid in between. And there's no runoff of the contrast. There's no runoff of the fluid. So I think the EVIS GJ with an EPAS balloon is very good if you have to do something beyond the DJ.
There's a question in the internet that what was your experience with exchanging the lens in malignant GO patients who live longer than expected?
I never had that luck.
So one question from me is that have you ever tried it if there's a complete obstruction, they could not put in a small bowel tube to inflate the small bowel lumen?
Sorry, I didn't get the question again.
If you cannot put in a small bowel tube to infuse the water to inflate the small bowel lumen, have anyone tried it to just do the FNA to infuse water to make it?
Yeah, it has been described in literature. I have not done it, but it's been described in literature, and that's the one that I showed as the first slide. They used to puncture the jejunal limb and inflate it and then do it. But when you do EUS, you see so many of the bowel loops, you don't know which one is which. So it's sometimes very challenging, at least for me, as to know which one I'm targeting. So I need a target structure to go by.
Do you ever try this freehand technique where you are not able to put anything into the small bowel? So what is your take about it? How do you identify where to puncture if you are not able to put anything?
Actually, most of the time we could insert the heating tube. So
you can. You put a nasobiliary drain. NBD is good.
So sometimes if the wire is not going there,
you'll find a way.
So I think in India they are very lucky to have a 10 French nasal delivery catheter.
Yeah.
In Hong Kong we don't have it. So if you cannulate it, you insert the 10 French nasal delivery drain, then you exchange the scope and then you exchange the EUS scope. So in Hong Kong we don't have the 10 French nasal delivery drain, we only have the 5 French. And it's very small and it's not good for dilating. So for us, we use normal Entroflex feeding tube, and we all know that the Entroflex sometimes is very difficult to insert freehand, especially there's a huge stomach, it moves in the stomach, and it takes actually the longest time it takes is to insert the Entroflex. Because the Entroflex is a 10 French catheter, I've had experience where I failed to insert the Entroflex and I used the bolted catheter, which is a 6 French catheter. It's still feasible, but it just takes more patience to inflate to distend the bowel. So I guess the gist is that the bowel has to be distended enough for a safe and confident puncture.
Yeah, so the whole idea is to make it look like a pseudocyst so that you don't have a challenge.
Actually, I used a 7 French nasal delivery drain. Serves same purpose.
Our department in Cochin, we have designed a new tube. Actually, it is similar to the original EPAS tube. So it has got the two balloons, and the advantage is that we don't need any over tube, and the stillet is stiff, and we are right now locally making it available, and we have done around 28 cases, and probably within 1 year it will come to the market.
Yes, I think Yenny Chen from Canada also designed a through-the-scope catheter, and I'm not sure if it might be available in the market.
Yeah, but I think it's a need of the hour actually right now. We need that.
So if there are no further questions, we can move on to the next lecture. EUS guided GV management.
So yeah, this is the other area which is quite interesting. Now, varices, as you know, are present in 50% of the patients who present with cirrhosis, depending on the clinical stage. If you look at the compensated cirrhosis, around 30 to 40%, decompensated 85%. The rate of formation is around 5 to 15% per year, and the sites can be esophageal, gastric, ectopic, starting from the duodenum, rectum, peristomal locations. Now, over 1/3 of the patient portal hypertension and 1/5 of them go on of non-cirrhotic portal hypertension do develop gastric varices. Now, the thing with the gastric varices compared to esophageal varices is the risk of bleeding with gastric varices is lower as compared that with esophageal varices. However, when it bleeds, the mortality and morbidity is higher, and 20% die within 6 weeks of index bleed. And the rates of rebleeding are high. Now, the way to deal with gastric varices has been direct endoscopic injection, TIPS placement, or use of the BRTO, or the balloon retrograde transluminal obliteration of the varices. So you can see at the bottom right end, that's the BRTO being done, and that's how you can improve a complete blockage of the variceal system. Now, the glue that we use is cyanoacrylate, and cyanoacrylate has been, there are different types of cyanoacrylate. We've got N-butyl cyanoacrylate, 2-octyl cyanoacrylate, isoamyl 2 cyanoacrylate. All of them differ in terms of polymerization times. N-butyl cyanoacrylate polymerizes within 1 second, octyl within 4 seconds, and isoamyl within 2 seconds. And what we have more commonly in India is the isoamyl cyanoacrylate. We did an ex vivo experiment comparing the coagulation profile of 3 different types. So we used thrombin and looked at, when we just have thrombin, we get a very loose form clot, very loose form clot here. Vis-a-vis, when you use cyanoacrylate, you get a very well formed clot, but it's still very splayed out. But with the coil and the cyanoacrylate, the clot is much more well formed, firm in consistency. So the clot is much stable. So if you look at direct endoscopic injection, now it has been in vogue for many years, and we have 6 studies which looked at it, and meta-analysis showed the cyanoacrylate is much more effective than banding, but the quality of evidence was poor. There's another meta-analysis in 2015 of 3 studies showed that cyanoacrylate is more effective than banding, but rebleed with isolated gastric varices type 1 is less with cyanoacrylate. But there are complications with cyanoacrylate glue, and one of the most dreaded complication is glue embolization, which can lead to on-table mortality. Of course, there are other complications like cast extrusion, sepsis, gastric ulcer formation, major gastrovarical bleed. The advantage with endoscopic ultrasound is that it helps us in precise localization of the varices. Use of a coil can reduce the volume of cyanoacrylate, and this can be used to target the perforator or the varix depending on where you want to inject, and you can confirm the obliteration of the varices. Now you can see this with an endoscopic ultrasound. You can very clearly see the varices and understand the variceal anatomy and find a site for puncture and delivery of the varices. So what we use here is Nestor coils, which are from Cook, and this is a coil that is coming in. So this is how the coil comes out of the needle. And as you can see on the surface of this coil, there are these thin fibers, and this acts as a scaffold on which the glue goes and adheres itself. So these coils are available in multiple different sizes. And if you look at the coil packaging, it comes in 3 different numbers, 35, 14, and 10 in each case. And here what 35 means is the recommended catheter ID, or the end hole diameter, which is 0.035 inches. The second number, 14 here, represents the embolus length, and the last number, or the 10, is the coil embolus diameter. And here what we are interested in looking at is the coil embolus diameter, which should be at least 1.2 times the diameter of the varix that you are targeting. So this is how we do the thing, and I'll just show you. So principally it involves getting the scope into the lower end of the esophagus and making a transcrural puncture and delivering the glue and varices into the varices. Now, the video is not playing. Can you just look at the video? Otherwise, we can move on. This one. It's not moving. Okay, for some reason this video is not playing. I wish we could have shown this because this is a good video. Anyways, so one is to put a glue and coil. The other one is to just use direct only coil injection. And here, when you have such varices which are multiple in location, almost like a lobulated grape-like structure, in those cases we can use to put multiple coils. And you can see one of the coils coming out here, and the second coil and the third coil. So the disadvantage with this is that we intend to use a lot of coils, increases the cost of the procedure, and not really effective. And why we say this is now enough studies which looked at using coil alone and coil with cyanoacrylate. And this is a meta-analysis which came out in 2020 from McCarty, and they showed that technical success overall is similar. However, when you use cyanoacrylate and coil versus cyanoacrylate alone, the technical and clinical success is higher. Cyanoacrylate plus coil versus coil alone is also the technical and clinical success is higher. So the combined injection of cyanoacrylate and coil works better than either one alone. So this is a randomized trial which looked at coils plus cyanoacrylate versus coils alone later, which came in 2020, and showed that the rebleeding rates are lower with the coil plus cyanoacrylate, and the varix reappearance rates are also lower when you use a combined injection. The rate of reintervention is slightly lower in the coils alone, but overall it seems that the coil versus cyanoacrylate overall reduce the rate of reintervention. Now, what the other advantage with EUS is that sometimes we have a direct endoscopic injection done of the varix, and on the luminal side, you do not see a large bulge. You can see the glue cast coming out here, but you do not see the bulge. In those circumstances, you can use the EUS and target the varix which is behind the glue cast. So that gives you a complete obliteration of the varicose wall. So this is followed by the cyanoacrylate injection, and that takes care of the flow in the glue behind it. This was explored by one of my good friends, Roy Mukada, and he showed that when you use in a patient with had a repeat direct endoscopic injection, use of cyanoacrylate plus coiling had a technical success of 100%, and the rebleed rates were significantly lower when compared to repeat direct endoscopic injections. So in the patients who have had direct endoscopic injection of the varices, use of glue plus coil reduced it significantly, the chances of repeat bleeding. Now this can also be used in ectopic varices, and in this case, as you can see, for some reason the videos are not playing.
Maybe you can try to move the cursor to the right most of your laptop, and then the cursor will be shown on the screen. Yes, and then you can control it with the cursor on the screen.
Okay, so I use the mouse, and this is how it goes. Okay, sorry. So this is again an ectopic duodenal varix. There's some problem here. Read something I can't see. Anyways, we move ahead. Not coming. Okay, we'll move ahead. Don't worry about it. So even in ectopic varices, it works well. So there was the question remains is there a role for direct endoscopic injection in the era of EUS guided interventions? Now, my good friend Jan did this study which we compared EUS guided glue plus coil alone versus endoscopic glue for gastric varices. And what have shown is that with the EUS guided glue and coil, the number of sessions required to obliterate the gastric varices were lower. In EUS guided gastric varices, the variceal size was higher, the amount of glue was not different. Abdominal pain was much lower with EUS guided glue and coil injection, and the rebleeding rates were also lower. From our center, we did a similar study. However, we found that there was actually no difference as regards early rebleed, late rebleed, length of stay, or mortality when we compared direct endoscopic injection versus EUS guided coil and glue injection. So the question remains, where is the evidence and where are we at it now? I think the jury is still out. So what are the problems with glue and coil? One of them is choosing the right side or right size of the coil. Now, as you can see, this is a large gastric varices. This is the early days of our thing. And when we are puncturing this with a coil, I'll let this video run. You can see the coil is now spinning like a top inside the varix. There's a high risk that this coil is going to fly out of the varix into the systemic circulation. So you have to choose the right size of the coil, and that's why those numbers are important, because when we say a 12 millimeter coil, the technician might read the middle number and give you this when actually it's a 6 millimeter coil. So that's what happened here. So these are early days, we were all learning, and that's what happened. So how do you stem this is immediately we followed it up with the glue injection, and that stabilized the coil from flying away. So once you put the glue, the coil remains. The other problem is coil extrusion, especially when you have a smaller size varix and you use a larger coil. The coil can then come out of the lumen towards the gastric lumen. This happens when you do a transgastric puncture primarily, and when this happens, that can be a site for coil bleeding. So here you can see we are puncturing the gastric varix, and it's a slightly larger coil than what we expected. And as we are trying to deploy the coil tends to come out towards the gastric lumen, and that becomes a nidus from where the leakage can continue to happen. And you can see this coming out of the lumen and pointing like a pin into the lumen, and that's the picture alongside it. So here again you have to just immediately inject glue just to make sure that the varix is thrombosed immediately. Now this is the other video. I'll just let it run. You can see they put a coil inside and something happens. I always wait for this reaction in the crowd. It gives a dramatic effect. So you can see now the coil is lodged there. So yeah, it's a good technique. You have to use the right size coil. If you do not use the right size coil, the problems that we faced with glue injection still remains with the direct coil injection too. So in summary, US guided therapy appears promising. Coils are improving safety of the procedure and reduce the number of sessions. We are now in the process of a large multi-center study in India where we are going to compare US guided glue and coil versus direct endoscopic injection. Thank you so much for your patient hearing.
So thank you very much. Before anyone asks any questions, can you go back to the slide where you read the numbers? Since you said that the call side.
I think that's something very important to understand this, because that's where all the goof up happens. So if you look at this picture on the right lower quadrant, where you have the Nestor coil, there are three numbers out there, 35, 14, and 10. The first number represents the coil diameter, or the the diameter of the coil, as in the caliber of the coil. So it's in terms of how you use the guide wire, 035-inch guide wire, or 25-inch guide wire. This is a 035-inch. The 035 can be delivered through a 19-gauge needle. The 035 guide wire or the coil can be delivered using a 19-gauge needle. The second number is the embolus length. Is the length of the embolus that forms. What we are more interested to know is the extended embolus length. So if you extend this coil, this is the length of the coil embolus that forms. The more important is when it crumples on itself and it forms a ring, what is the diameter? That's what we are more interested in. And this is the number that you have to look at. And here in this case, on this picture, it's 10 millimeters. Sometimes it'll be 10 or 12 millimeters. So the coil embolus diameter is what we should focus on. The first number will determine the gauge or the caliber of the needle that you use, and the last number is the size of the varix that you use it to.
So say, for example, your GV you measure it's maybe 1.8 centimeters. Then what coil size would you choose?
1.8 centimeters would need a 2 centimeter coil.
So is there any minimum size of, so now that you've this technique is so successful, so is EUS GV coil embolization and glue your first line of therapy as compared to a direct injection?
So if I'm not sure, so our algorithm is very clear in the sense that if there's a large varix, more than 1 centimeter, isolated gastric varix, we would prefer EUS guided glue and coil injection over direct injection.
Do you do quarter milligram?
No. No. The thing is that I can only do what I know. So I don't understand portal venogram. I'm not an intervention radiologist, so I'm not going into that area at all.
There is a large collateral. That's what I.
So the question is large collaterals, whether we do it. So we are doing varicose injection. We are not trying to block off the collaterals or the feeders. We are doing direct transluminal injection of the varix. The only difference between direct endoscopic injection versus this, we are adding in coils. So we are not interested in doing injections of the what you call the flow tracks.
If I can just make a comment, so I think that's why there's a push now go to BRTO as a first line. Our center, we use that as a first line because you can block the bottom part and you fix everything, including the
I agree, absolutely.
We only use coil and glue if they fail. If the vessel is too big for them to coil and block, then we have to use this as a second line. So we do this, but not as often as before.
I agree with you, and I think BR2 gives a thing, but BR2 is primarily helpful when the patient is stable and not bleeding, a thing. But if you have to do it in the endoscopy room and the patient is bleeding, I think that's when the EUS comes into place. But BR2 is a very, very good technique and probably will outshine EUS guided interventions.
So I have two questions. First question is that, so the second number that we talk about, the length of the extended annulus, is it variable? Because I thought
this number varies between the different. If you look at all the numbers, all of them will have different numbers written there. So it's not something that, look, for the second one, as I said, it's a 35, 14, and 12.
Yeah.
So these numbers are variable. This is mainly interventional radiologic coil that we use. They use for blocking
so
of our.
For Nestor, I have tried to inquire from the Cook people, but what I got from them is the size that we use, more than 12 mm, 12 to 20 mm we will be using. So the part 35 and 14 is standard for them, and
the one in the middle
part that varies is the diameter of the
right. Yeah, right.
The second question that I want to ask you is that in a patient who's like we had it recently, a patient presented with bleed. On endoscopy, he was having large esophageal varices with red color signs, and there was a large gastric varix. So how would you manage this patient?
So in those circumstances, we tend to target the esophageal varices, and if they continue to bleed, we do a Barto.
So the question being, in presence of esophageal varices,
I don't do a EUS guided intervention primarily because most of my interventions are transcrural. I try to do a transcrural puncture. So I avoid doing it when there's an existence of esophageal varices.
Even in small esophageal varices,
I would try to avoid it.
You will avoid it. Okay.
Large varices in our department, what we do is that if the size is more than 1.5 centimeter, and we are deploying the coil, the last 1 or 2 millimeters, we are deploying it outside. We have found that bleed occurs from that side, and immediately you inject glue into that, so it will stay there and avoid embolization.
So just an interesting question, so can we extend this to ulcer bleeding? So if we do have a DU that is bleeding and we can't stop the bleeding, can we just switch to an EOS scope and find the GDA and embolize it, because that's what the IR people do anyway?
Yeah, I haven't done this. It's an interesting thought. We did do a small series on aneurysms also, and small aneurysms up to 1 to 1.5 centimeters could be easily blocked with the thrombin and coil placement. I haven't used glue, I used thrombin in that. But anything larger than that doesn't tend to work very well, at least what our experience has been. So yeah, aneurysms, yes, but I've never done directly into an artery, no idea.
Do you do it under X-ray guidance every time or just under US guidance?
Under US guidance.
No X-ray.
Yeah.
So there's a question, have you ever encountered FNA needles stuck inside the varices after the glue injections?
Thankfully, no. Thankfully, no. We haven't had this. I know it's described even in direct endoscopic injections where the needle gets stuck. Thankfully, so far, haven't had it. Maybe when we do around thousands, we'll start seeing them. But as of yet, we've not reached that complication.
Do you think there's a risk that if we do the FNA needle directly injected into the perforating ring, would the glue or coil just go away?
Yeah, that's the problem with that is that when you do an EUS, what you can easily identify is the intraluminal extension of the varix. What we look outside the varix or the extramural portion of the varices, you see multiple vessels around there. To know which is the efferent, which is the efferent, I think it's extremely challenging. And without, as the doctor mentioned, without a portogram, you cannot say that. So I don't go into that area.
So you would not directly puncture the perforating?
I would not try to do a perforator. I do just do a direct endoscopic injection of the varices. And so far we have had very good success with that. So stick to what we know.
So I also have a question that I've always wanted to ask is that when we do direct injection, we give a powder, we give fluid, we give a powder to avoid blockage and stuff. So why don't we need to do that in EUS injection?
So I think almost 17 years ago, we were still doing lipoidal, but nowadays we don't do lipoidal. We use just direct diluted saline. So even for direct injections, ours has been with distilled water, glue, followed by distilled water. That's all we use. We don't use lipoidal in our center at all. Lipoidal tends to make it very hard. It's very difficult. It's a very sticky thing, so it's difficult to push it in. And in the EUS thing, if there is a delay, the chances of that blocking the catheter itself exists.
I think we are prohibited to doing that. Our endoscopy nurse will say we will block the channel, then we will get.
I think that's a miss. So you can actually demonstrate to the nurse because actually that when I came back and they typically ask me to use lipoidal. So we I take a needle out, inject the glue and flush with saline and everything went through nicely. So you can convince them that actually you don't need to use lipoidal.
No, I know because back in there also I was using lipoidal, but I found it challenging, so I went back to thing.
So Raymond, are we still using the paddle?
For a few reasons, probably not. Sorry. Yes. So right. So actually, this only represents kind of the local experience. So why we still mix a little bit of the paddles, we want to know what happened to the glue afterwards. So because with the lipoidal, so at least now we'll feel better. For example, as a post follow-up X-ray, then I see, okay, it stays kind of below the diaphragm, I feel good. But if I start to see stuff in the lungs, then I know, okay, something probably happened.
I know what you're talking about because I did a few under fluoroscopy with lipoidal. I stopped doing it because it only increases my fear because moment you inject it, you see more in the lungs, it's kind of scary. So what the mind doesn't know, what the eyes do not see, I'm happy there.
We forgot to introduce Professor Nam. He's pretending to be a participant in this AEG workshop, but in fact, he's a professor in gastroenterology and also an expert intervention in the US. I'm not sure why he's here as a participant. I'm kidding. He's here he's organizing a TGT in his center at the end of the year. So he's just here to observe how we're running the course. But he's also very experienced in intervention in the US. So if you do have questions, you can also go and ask him.
Thank you.
Okay.
Thank you, everybody.
Thank you very much. So now we have finished the morning session of lectures. In the afternoon, we have a few cases of live demonstration that will start at 2 at our endoscopy center. And I think the lunch will be served here. You can bring your lunch into this room. So we'll bring you down when you're ready downstairs. So enjoy your lunch.
Yes.